speaking to us amongst the topics of their expertise, health financing, which is our topic for this particular meeting. We are going to receive two presentations from our resource persons. The first presentation will be about mobilizing resources for health sector and the role that parliamentarians could play. The second presentation will be on allocating and spending resources efficiently and the role of parliamentarians in ensuring the same. Before we move on to the presentations, honorable members, I would urge that we introduce ourselves again today for the purpose of the resource persons to know who they will be speaking with today, as well as any members who may be joining us for the second day who may have not been here yesterday. So,
thank you so much, Honorable Chair. Perhaps before your members go into the introductions, we have one housekeeping announcement, I think, to make for the honorable members to take note. Honorable members, you should take note that our proceedings or your proceedings are live on YouTube. So that being the case, it means we are being followed all over the world. So it means our conduct and all what we are doing, we should be mindful of that we are very much live on YouTube. We should take note of that. I think that is very, very, very important because you never know who is picking on you and what you are doing at any particular time. Yeah, perhaps again, before you open up, Honorable Chair, for the introductions, you may wish also to invite the Secretary General. She may also wish to say a word before you proceed with the introduction and the rest of the program. I thank you, Chair.
Thank you very much, Mr. Joseph. I was actually thinking to bring in the Secretary General before we invite our resource person to speak with the team. But however, that is not a problem as well. I can invite Madam Secretary General to speak a bit and make few remarks regarding the business of the day and possibly some recommendations on how to go about the interactions for today, which are quite important for the members, given the gravity of information that we expect to get out of the presentation. Madam SG, before introductions by members, would you want to make a few remarks before we proceed?
Good morning, honorable members. Bonjour. Bon dia. Honorable member, Chair, let me not make any remarks at the beginning, save to make one apology that the presentation is in English. Once we receive it, we'll translate it and share it with honorable members for their benefit. And maybe, Chair, at this point, you may wish to defer to Dr. Riro, who will introduce Chai and introduce colleagues who are joining us online for the benefit of members who may also wish to explore partnerships at country level in this regard. Chair, if you allow, I will, if at all, say something towards the end after the presentations, Chair. Thank you.
Thank you very much, Madam SG. Thank you very much for the guidance in terms of how we can start our introductions. So we'll start our introduction with the CHAI representative, who is our resource person, coming to share presentations with us today. We would kindly request that they make the presentations, they make the introductions of themselves for the members to really understand who they are and maybe the organization overall, just to have an understanding of the work that CHAI does. And then after that, we'll have members do their own introductions for the member to be able to know who they are speaking with. And then we'll then call upon for the presentations to continue. Thank you. Member, our resource person from Chai, would you kindly take the platform and introduce yourself to the team? Thank you.
Good. Thank you. Thank you very much, and greatly appreciate having me here. To the honorable members, I really wish I was there in in Johannesburg, but I'm really honored to be amidst you, even though I'm doing this virtually. But I greatly appreciate you having me today. The and also much gratitude to the Secretary General for inviting us to share with you some of the work that we've been doing across the region. And I greatly appreciate it. Don't take this for granted, especially having at this high level to share this with you. So my name is Dr. Matikoriro. I'm Associate Director for Health Financing at the Clinton Health Access Initiative. I'm based in Nairobi, Kenya. And as you can see, I just thought I'd give a quick brief overview around some of the areas where we work. I know my colleagues should be joining shortly. I was actually looking through the list who has joined, but I think when they join, we'll do the introduction as well. But I just wanted to just give a quick overview around our work. So we do work across 40 countries. Doing this for the last 20 years, from the year 2002, and most of our staff are based in countries that we work in. So if you look at the map that I've just displayed, it essentially shows, especially in the South and Eastern African region, where yes.
Yeah, apologies. I'm being informed here by the technical team that they can't hear you quite well. Would you kindly be a bit closer to your mic and try to speak a bit slower, because we have the interpretation going on, so they're not receiving you quite well. Thank you. You can proceed, Dr. Riro, so that we get feedback if we can receive you well on our side.
Yes, I've moved closer, but I don't know whether you can hear me quite clearly. Maybe you can give me feedback on that.
Yes, this is much better. I'm told this is much better. They can hear you.
Good. Thanks. So maybe I'll have to repeat that. So earlier on, I was saying that, so my name is Dr. Matikoriro. I'm a medical doctor by profession and a health economist, currently working as the Associate Director, Health Financing at the Clinton Health Access Initiative. I'm based in Kenya, in Nairobi, Kenya, where I provide a lead our technical support for our teams across the continent to drive health financing reforms, more specifically, supporting governments in driving reforms that can lead to improved coverage for our populations across the continent. And one of the areas I was highlighting as I showed the map is actually we are in over 40 countries, and we've been doing this for the last 40 years, with most of our staff based in the countries that we work in. And interestingly, if you look at the map that I've just displayed, a significant, almost all the countries in the South and Eastern Africa region, we have our presence in those countries. And so I'm happy part of the conversation today is really to give part of the lessons learned, not only some of the work that we do across the countries in the SADC region, but also even moving over and thinking about what about the other countries in Africa or Asia, what sort of lessons can we learn from there for us to meaningfully see how can parliamentarians be involved in driving some of this change, being some of the key players that we work with. So I'll wish to pause there for now, and maybe I'll give further details, but I just thought I'd give just a quick overview around what we do, and also just highlight that in most of our country programs, we have our teams embedded within the government to give sort of continuous support with a good mix of regional expertise, so that we can share some of these learnings. And probably this one of those areas that we were looking to share, with the aim that we scale very high impact in interventions across the region. So really happy to be here and looking forward to this conversation. Thank you.
Thank you very much, Dr. Ego, for that introduction. Before we dive into the presentation, we would also like you to know who you're speaking with. So I'm going to have the members also introduce themselves to you. I'll start with the members who are with us here in Johannesburg physically. Then I will also ask members online to introduce themselves because we do have members who have joined virtually just like yourself. Honorable members, I'm going to request you all to introduce yourself. The table of the chair will start, and then we'll move just like we did yesterday from my near left to our far right, and then we'll have members online to do the same. Honorable members, my name is Mope Khati. I'm the chair of the Human and Social Development and Special Programs Committee. I'm a member of parliament from Lesotho, and I'm honored to be here facilitating the meetings today.
Once again, thank you, Honorable Chair. My name is Joseph Manzi. I am the Director of Programs and Parliamentary Business in the SADC Parliamentary Forum. I am sitting in this meeting as the committee secretary for the committee. Thank you so much.
Thank you very much, Honorable Chair. My name is Moses Magaza. I am the Media and Communications Manager at the SADC Parliamentary Forum.
Good morning, honorable members. Good morning, honorable chair. My name is Paulina Kangwashibi. I'm the Assistant Procedural Officer and Coordinator at the SADC PF. Thank you.
Good morning, honorable chair, honorable members and colleagues. My name is Maria Mombola. I'm an official working for the Parliament of Namibia and also the SADC PF desk officer. Thank you.
It is a good morning. I am Clopas Kwakwara. I'm with the Parliament of Zimbabwe as a protocol and SADC PF desk officer. Thank you.
Good morning. My name is Aida Kombe, desk officer from Tanzania Parliament.
Yeah, good morning, honorable members. Good morning, everyone. My name is Agnes Mingana Kafula. I'm a member of parliament from the Republic of Namibia. Thank you.
Good morning, everyone. My name is Leonard Marwanda, MP for Malawi Parliament, sitting as a proxy for Honorable Echo Zulu. Thank you.
Monsieur le Président, monsieur tout le monde, je m'appelle Dr. Pierre Louvanirina Célestin. Je suis membre du Parlement de Madagascar et membre de la commission ACS-DSP. Merci.
Good morning. My name is Kasim Hassan Haji, Member of Parliament from Tanzania.
Good morning to you all. My name is Lynette Karenyi, a Member of Parliament from Zimbabwe, and I'm the Deputy Chair of the committee.
Good morning, Honorable Chair, Madam Secretary General, and esteemed colleagues. My name is Senator Linda Ngumalo. I'm from the Kingdom of Eswatini. I'm a member of this committee.
Thank you very much, honorable members who are with us here physically. I will then pass on to members who are joining us from online. Would you kindly introduce yourself, honorable members? Madam SG, maybe you could take it up first, and then the rest of the members can follow.
Thank you, Chair. My name is Boemo Sokuma. I'm the Secretary General of the SADC Parliamentary Forum. I'm happy to have Chai on board and wish to place our appreciation on record for your participation and really committing to sharing your results with this committee. Thank you, Chairperson.
Honorable members from online, could we follow Madam SG, no introductions? Kindly introduce the country you come from, if you are a member of parliament. And I see honorable member from Seychelles raising up their hand.
Good morning, everyone. I'm Kelly Saminade, MP from the Seychelles and a member of the committee. Thank you.
Honorable member from Angola.
Bom dia, senhor presidente. Bom dia, senhora secretária-geral. Bom dia, ilustres colegas. Eu sou Luísa Damião Santos, do Parlamento angolano.
Good morning. I am Samuel Bokwasi. I'm the internal auditor at SADC PF. Thank you.
Good morning, honorable members. My name is Rachel Mundilo, and I am the program manager for the Committee on Food, Agriculture, Natural Resources and Climate Action at the SADC Parliamentary Forum.
Any other members? Okay. Thank you very much, Honorable.
Sorry,
Yes.
Chair. Yeah. I see Cynthia Chachi, Jeff Zulu. Kindly introduce yourselves, or you are not in a position to. And I see Marilyn Mwinjo. Sure.
Yeah. Madam Secretary General, I would like I had mentioned earlier that one of my colleagues will be joining shortly. So one of my colleagues, Cynthia Shashi, has joined. So she is the rapporteur of the session this morning, and I'd like her to introduce herself. Cynthia, please.
Good morning, everyone. My name is Cynthia Shashi, and I work with Matiko at the Clinton Health Access Initiative as a country focal person, supporting several countries across the region. I'm happy to be here to be your rapporteur.
Thank you.
Good morning, everyone. My name is Marilyn. The surname is Mwinyo, and I'm with the National Assembly of Parliament of Namibia in the Office of the Speaker, and I'm an SRHR researcher. Thank you.
A member by the name Jeff Zulu. Honorable members, I want to believe some may not be in a position maybe to introduce themselves, but just to take a record of members who are online, members representing the parliaments. We do have honorable member from Seychelles. We have honorable member from Angola. I want to believe those are the members that we have now online. This is quite important so that we keep referring to them and speaking with them during the proceedings. At this point in time, honorable members, as I had mentioned and had our resource person introduce themselves, I'm going to ask you to help me to welcome and invite Dr. Riro from Clinton Health Access Initiative to give us the first presentation. And as I did mention, the first presentation is on mobilizing resources for health sector and the role that members of parliament can play in doing the same. Dr. Riro, I would like to open up the floor for you to make the presentation. But before you come in, I just want to emphasize to the members today that it is with great pleasure that we have the experts amongst us today to be able to give us data-based evidence around what are some of the interventions they've been dealing with across Africa as far as health financing is concerned. It is important and critical that we listen thoroughly, be able to engage after the presentations, because this is information that will then support the next sessions that we are going to have on trying to put together the recommendations for the 56th plenary that will be taking place in Zambia. So it is important to engage our expert resources in terms of comments, in terms of questions and clarifications, so that we are well informed and in a better position to put together actionable recommendations that could then prove our report to be of the highest quality possible. Having said this, Dr. Riro, I would like to give the platform to you. Honorable member from Angola, I see your hand is raised, but I want to believe that was when you were presenting, introducing yourself. Is that the case? Would you kindly lower the hand so that we know when you have a point to raise? With this being said, Dr. Rio, you're welcome. The platform is yours. Kindly go ahead with your presentation. Thank you very much.
Good. Thanks again, and definitely a pleasure to be here. And I'll probably just slowly take you through some of our learnings across the region, more so looking at the trends. But at the very initial stages, also get to understand this phrase that keeps on coming up called universal health coverage. What are countries in the region doing? How are we doing? And what sort of implications and what role does the parliament play in driving the UHC agenda, or what we're calling the universal health coverage? The other important part is around what is the role of parliament and all of us who are sitting in this forum in terms of increasing the move towards this universality through either prioritization and efficiency gains that we can do. Then go again even further to the practical examples of efforts that most of the countries have been making towards UHC. So I think we begin from here that, different countries are at different levels of mobilizing resources, especially for the health sector. So if you look at the table that the slide that is right in front of you, is trying to demonstrate where is the money coming from to the health sector across the different countries according to their income levels. So if you look at the low income area, the low income countries, the blue color represents domestic resources. What resources do we have as a proportion of the total expenditure in the country? Then the orange one represents the prepaid. So, for example, the insurance mechanisms that are involved in this. The gray one represents the out-of-pocket expenditure. So how much money are people actually spending out of pocket to access care? And the yellow one represents the money that comes from outside, the donor funding. So DAH, that's development assistance for health. So if you look at the first one, especially because some of our members lie in this area, is also trying to see how, and part of this conversation that we're having today, so clearly see how can we improve domestic resources for health, but also acknowledge that a lot of these resources, especially in the first group of countries, are coming from outside. No, actually coming from people's pockets. And I'm going to talk about it later in terms of why are we worried when people have to pay for their care. So in terms of trying to move, why should we move and why are we talking about this? So if we're talking about this, then we can see that sort of moving in the next group of countries, that the lower middle income countries that have probably there's just a slight increase in terms of domestic resources, slight increase in what you're calling the prepaid mechanisms, that is especially those who have set insurance systems. And by this, I'm talking about, Zambia that has recently set up a health insurance system. I think, for a long time, South Africa has had a very robust health insurance system. And I'm going to talk about that shortly. But also you can see a significant chunk of health expenditure is out of pocket in those countries, especially when you're talking about the countries in the region. And then when you go up at the upper middle income, then you see slight increase in domestic resources, slight increase in the prepaid mechanisms, but still we have out of pocket expenditure, and with a very thin margin of development assistance or donor funding. Then the same thing can be seen in upper income countries, especially in in Europe and the US and some countries in Asia, where you're talking about domestic resources, quite significant contribution from prepaid mechanisms, that's insurance, and again we have out of pocket as well. So, but what is the point I'm trying to make? That what we should aim at, especially in all these trends, as much as possible, let's raise domestic resources in whichever mechanism, either through prepaid mechanisms or through taxes, but reduce out-of-pocket expenditure, because when people have to access care because of their ability to pay, then a lot of them forgo care, and that has consequences in terms of them really accessing care, improving their livelihoods, or having to forgo food to access care. And so we should be driving, and especially as parliamentarians, one of the messages I want us to get from this table is how do we slowly increase blue? How increase blue is about how do we, even budget negotiations, how do we prioritize healthcare so that we increase the blue color? And if we're to increase the orange color, a number of countries, and I earlier mentioned Zambia, which instituted health insurance systems, the National Health Insurance Management Authority, that then is trying to increase that sort of yellow, so orange, so that we increase both blue and orange, and as much as possible reduce gray and yellow, because then most of the countries and donor countries are pulling back in terms of their donor support. And so if we don't take that up, then a lot of this might still end up with people paying out of pocket. And so this trend basically is just to drive a rallying call to members of parliament in terms of what role do we have to increase the blue and potentially the orange and reduce the yellow one and the gray one as much as possible. And so if we still on that, just looking through the countries across the continent, how are they financing the care? Again, just trying to see, and especially looking at how much do they spend. If you look at the total expenditure in health, if you now divide the total expenditure as the population, you see the trend, how it comes. So in Malawi, we're having an they spend about $35 per person. Oh, and again, I have to give a caveat that this is the data from 2018. Then most of the countries now are generating new data for 2024, 2023, 5 years later. So probably this has slightly changed, but I just wanted to show some kind of a trend, how this happens. And so we're looking at Malawi spending $35 per person. If you were to look at the total expenditure, then divide by the population. Total population of Malawi. Ethiopia follows with almost the same at $36. Then we come to Uganda going at about 43. But you see Rwanda slightly up at about $58 per person. Then Eswatini, Nigeria goes to 84. Eswatini about, we have Eswatini doing about $271 per capita, that's per person. And if you look at the total expenditure they have in health, then you divide it by the population. In South Africa, pretty high. I think they're leading in the continent at $526 per person. If you look at the total expenditure and then divide by the population. And so I think this also helps us to see, as members of parliament, what role do we have? If at all we're squeezing, you're saying that per person we're spending $35, then we have to imagine the amount of health and care needs that population have, and what do we have to do to increase that? That's at the very basic, think about increasing the expenditure at that level. And even still looking at the trends, especially around in the individual countries, in terms of how is the money coming in? What is the contribution from the different sources? I know in the previous slide, I was mentioning in terms of the bigger buckets of low income, upper middle income, and all that. But what you see here is in Malawi, for example, the purple one, that's development assistance for health, accounts for quite a significant chunk of almost over 50% of the health expenditure. And out of pocket comes in, and you see Malawi having domestic resources accounting for about 25%. And so as members of parliament, especially Malawi, then we should be pushing up this in terms of how much we are allocating to this, or coming up with mechanisms of prepaid approaches and reducing as much as possible the out of pocket. If you move to another country in the region that we're talking about, let's go to Eswatini. So Eswatini, you have about, slightly above 30, almost 30% in terms of domestic resources, but we still have a significant chunk of our budget being supported by donors. But with sort of a good mix of out-of-pocket and prepaid mechanisms. And so trying to see how do we address, especially this part, and as members of parliament, what role are we playing in making sure that there are more domestic resources in Eswatini that actually are able to catch up as donors, plan on an exit out of the countries that we work in. When we go to South Africa, quite as a great sort of mix in terms of the domestic resources. But the other part is just the insurance systems in South Africa, which contributes quite a significant chunk. So you see, in South Africa, we can confidently say that over 90% of the resources are actually domestically generated, either through taxes, that's the government itself, or through what we're calling the prepaid mechanism or private health insurance in South Africa, which is quite robust. So we have probably slightly over 5% in terms of out-of-pocket expenditure with a very small margin of donor funds. And so I just wanted us to have a look at that. But it becomes even interesting when now we overlay this in terms of some of the indicators that we're talking about. So when you're looking at maternal mortality, for example, in Malawi, we have a maternal mortality ratio of per 100,000 live births of about 400. So what that means is 400 mothers out of every 100,000 live births die. And this can easily be, if you look at this and compare with the amount of money spent, there's stronger evidence that the less you spend, the more you spend in the health sector, the better results you get in terms of reducing maternal mortality or neonatal mortality. So this is a trend that becomes interesting to have a look at. But again, sometimes it's about how we use the resources efficiently, because if you compare, let's say, Rwanda and Nigeria, so Nigeria spends more than Rwanda, but you can see what the difference in terms of maternal mortality and neonatal mortality that there is. So actually, there's the aspect of spending, but there's an aspect of spending well. And I know later in this morning I'll be talking about, yes, it's important to raise money, but it's also important to drive policies that spend the money well. So in terms of allocate the money to where they're supposed to be and efficiently, so that you can get what you actually want. And in the health sector, the primary goal is to save more lives and to prevent deaths, and at least to keep the population healthy to produce. And so looking at this brings quite an interesting mix in terms of what we can look at. And, so this slide, I'm happy again, I know we'll get to the question and answer session, but happy just in case there's certain questions you want us to interrogate in terms of how best, even as parliamentarians, then can we move these levers to make sure that, one, we have not only respond to the, even within the donor landscape, how do we help in terms of making sure that there's stronger aid coordination mechanisms, or even a transition plan as all these donors tend to think about exiting. So that's something that I'm open to a longer conversation this morning, just in case we have that at the time when we'll be talking about the question and answer session. So I think that again transitions us to thinking about what about this whole element called UHC. I know a lot of countries and a lot of you in parliament keep on hearing the word, oh, let's work towards UHC. It's also one of the aspirations of the sustainable development goals, SDG 3. So how do we move towards that? And I think that becomes interesting for us to think about. But what do we understand by UHC? And I wish us to, especially as members of parliament, to see it as that ability to ensure that all people and communities have access to promoting, preventing, curative, rehabilitative and palliative health services of sufficient quality, and making sure that when they're going to access it, they don't suffer financial hardship. It's interesting we can have all the best machines in the country, but let's make sure that people do not have to sell their land or to forgo education, to forgo food to access care. At the very least, we should be able to ensure that the services that they need, at least essential services, they have to access it without having to go through financial hardship. So what we have to think about, as much as we're aiming towards a comprehensive care package, is we have to balance that. What about the need that the population has? Not only that, what about the quality of the service that we're talking about? But most importantly, making sure that there's financial protection. Financial protection meaning that people are covered in a way that they have to, when they access care, they don't need to, to forgo the essential needs or have to go into financial hardship while accessing that. But again, as members of parliament, what we have to think about is how much is this? And the previous slide was showing in terms of what do we drive domestic resources and how soon should this happen? And how do we pay for it? And I'm going to talk about that later this morning in terms of what best approaches can we do to make sure that we pay for it efficiently. So to do this, there are things that we need to keep in mind as problems that we always have to think about as parliamentarians, even as we advocate for all this. That there is, the healthcare needs are many, but the resources are always limited. And so all we have to think about is how do we balance the needs and the resources available, even as we advocate for the budget. So that means we have to call for accountability in terms of where we put the money, do we actually get the healthcare that we actually deserve to get? But the other bit in terms of one of the problems is to imagine that we should, at the very least, make sure that people don't get impoverished due to medical expenses. And to do that, then it's all going back to the areas that we talked about in terms of mobilizing more resources into the health sector. But also, let's make sure that people do not lack access to health services, either physically. So in most cases, what we're seeing in countries across the region is, yes, we could be having health facilities, but they're far between, and people have to incur, as much as you have health services available, there's also the barrier that comes in terms of transport costs or travel costs. And so we have to think about how do we make sure that as we are making sure that the financial barriers are removed, we also make sure that the physical barriers are removed. And so those are some of the areas that become very interesting for us to think about. And what I was highlighting earlier is all this is envisioned by the Sustainable Development Goal 3, that is looking at equitable health outcomes and well-being, with all these others around making sure that we have financial risk protection and also improving healthcare access. But also acknowledging that UHC, the whole concept of UHC is not new. And it's just that we're seeing more increased sort of focus, especially across countries, especially under the SDGs. But what are we talking about when we're talking about UHC, especially now putting into context the Southern African countries, as we think about this, and probably thinking about what role can parliamentarians play in driving this. So what we have to always, so this is what we call, in most cases, what we have to do is we call a UHC cube. And just keep in your mind that this cube represents the whole population that you have in your country. But also, what the cube presents is trade-offs. That by the time you're moving to UHC, there are many balancing acts you have to do. So the first balancing act that you've got to think about is who should be covered. So do we cover 100% of the population? Should we focus on women? Should we focus on children? Should we focus on the poor? Should we focus on the elderly? So we have to keep on balancing in terms of who do we cover in all this with the money that we do have. Earlier on, we said, let's have more money. But again, we can only have so much because there are competing interests within the countries. As you imagine, there are schools to be built, there are roads to be built, there's agriculture to be improved as well, there's water to be provided. And so all these are balancing acts that we've got to think about. So can we offer 200%? That is the ideal of the population. But again, we have to choose. Sometimes let's go to the most vulnerable populations that we are thinking about. But even if we said we cover 100%, can we cover all the services? Can we say we're going to cover all the way from malaria to all the cancers, to all the non-communicable diseases, to all the surgeries? Probably not. So what you have to think about is what services and interventions should the population of different groups be covered for, even within that whole conversation. And once you've decided and said, okay, I've covered this group of population for these services, but the other point is, what proportion of those costs? Are we going to pay 100% for, let's say, renal transplant? Are we going to pay 100% for surgical procedures? Or are we going to pay just a fraction, then there's a copay and all that? So these are really balancing acts that a lot of governments have to do. And in Parliament, what role we play is driving policies that at the very least, make sure that the vulnerable population, especially around addressing the question of equity, that we have populations that are underserved or hard to reach areas at least covered. And then we have to think about what we actually promised to cover is actually happening on the ground. So there is a promise, but also the delivery. How do we make sure that all this thing is done in alignment with that? And the other bit is, after all is said and done, how do we make sure that the quality is also up to par? Because in most cases, what happens is, yes, we promise this package, but actually the population does not get the quality they deserve. And so what happens is that it reduces the healthcare utilization. So you're seeing a number of countries are saying, yes, for us to reduce maternal mortality, let's remove user fees for let's say ANC and mothers delivering, but mothers still not going to the hospitals. But what is driving that? Most of mothers feel like they are not, most of them are pulling away from health facilities largely because of quality concerns. And of course, sometimes I say, yeah, but we have doctors there, you have nurses there, but sometimes quality is as defined by the user. And so let's try to be quite keen in terms of the feedback that what mechanisms as Parliament have we put in place to empower patients to actually provide feedback in terms of the areas that they're going to do. And finally, on efficiency, we must make sure that we're maximizing value of the money that we're putting in. We can spend all the budget in the country, but if we are not putting in the right places and actually making sure that the commodities, we have clear mechanisms of commodities reaching there without any sort of wastages. So all this to make sure that we maximize value to improve efficiency. So this is really to give you a brief overview of, as parliamentarians, when you're talking about UHC, what sort of policy questions are we talking about, and how can we best handle it as members of Parliament to drive policy change, especially in allocating money towards the health sector, making sure that some certain services or certain populations are prioritized, and especially when you're talking about, and I'm sure a bigger chunk of our work also focuses on things like maternal health, sexual reproductive health. So that becomes an interesting thing for us to think about. So there are multiple perspectives of UHC that I want us to keep in mind, especially from a legislative perspective. So one is the legal perspective. So there is need to build legislation that defines rights and protects rights and protection, that build mechanisms to protect the rights to health. And so I know a lot of constitutional dispensation across the SADC region really have it clearly outlined in the Constitution on health care as a right. And so what we should always be saying is, this is not that we're going back to ask for more. It's actually something that is already in the Constitution. And so for us to think about, let's think about it as a right, just like any other rights. There's a right to life, there's a right to health. And so let's protect it, and let's channel resources to actually make sure that this is protected. And also all the areas of health sector. If you're talking about sexual reproductive health being one of the rights, then let's think about it from that perspective. That is, we have a mandate to drive resource allocation to health and to all the other areas of health that have already been entrenched within the Constitution. The other perspective that we can have, especially as members of Parliament, especially in all these conversations around mobilizing resources to the health sector, is advocacy perspective. And so let's be clear around identifying the underserved and vulnerable populations to ensure that there is representation in a dialogue around UHC. Because some cases we see if people who do not have a voice are not on the table to define some of these services, then a lot of their voices is lost, and so their services are underprovided. So let's be clear around who on the table, how do we create laws that make sure that there is public participation, and especially of populations that are underserved, because there is potential for them to be left out, especially when you're coming to resources being allocated to them. And thirdly, is the health system's perspective. So it's, sometimes it's harder to look at just one way and say, let's throw money at the problem, because healthcare is complex. So the World Health Organization comes up with a system of thinking about this and says, think of a health system as a house, and this house is held together by 6 pillars. So the World Health Organization identified 6 pillars that hold this house called a health system. So one is health financing. So we need the money to drive policy change. And so as we think about this as members of parliament, let's think about it from that whole health system perspective and see how are we looking at health financing as one of the pillars that hold this house together. The second pillar is on health commodities. So we're talking about medicines, vaccines, or even diagnostics. So all these health products and technologies form a second pillar, which is core. So you can have all the money, throwing it at the system, but if it does not result in availability of commodities being at health facilities, then becomes a whole other perspective. So even the laws that we do make to mobilize it, so let's think about commodities, how we shape them moving down, and also essential commodities that are addressing some of what I've mentioned earlier, the underserved populations. So those are the 2 pillars. The third pillar is the health workforce, or what we call the human resources for health. The nurses, the doctors, the pharmacists, the lab technicians, all through is what are we thinking about in terms of being clear around how we build a clear pipeline of health workers to provide this. Because we can have commodities, we can have the money, but if we don't have the health workers, then that house isn't complete. So think about those first 3 as just being complementary as such. This 4th pillar is service delivery. So once you've had the 3 pillars, then the other bit is we need to deliver the services. We need to monitor how the service is delivered. We need to be held. All these other pieces need to be accountable. We need to hold accountable to the health workers in terms of the quality of service they provide, or even being present at the places of work to deliver the work that they're supposed to do. So that pillar in terms of service delivery encompasses things like the quality of care and all that. So that's the 4th pillar. The 5th pillar is the health information system. That it's good if we provide it, but if we don't have a clear mechanism of documenting it or reporting it, either through, I know a number of countries are running district health information systems, or what we call DHIS2. A number of countries have booklets. Every mother, when in a number of countries, when you go, they have a massive motherhood book that is recorded when they go to the clinic for ANC. So these health information systems play a bigger role in terms of we should track patients, and especially a system where people are coming far between, they visit different health facilities at a go. So we need to have that sort of clear perspective. And finally, the last pillar, which is the 6th pillar, I mean, there is no order in all these pillars to mean that there's one which is more important than the other. But the 6th pillar is what we're calling leadership and governance. So all is good, but we need to strengthen the leadership of the health sector so that, all this is well coordinated and there's clear stewardship, especially from the Ministry of Health, not only at the national level, but even the sub-national level. You're talking about the districts or the provinces, as it is the case in South Africa or some of the regions. Then we're thinking about how do we not only do some of the leadership and look at it from the national level only, but also the district or the local government are looking at that. So that's the perspective that I wish us as members of parliament to keep on thinking about in terms of how that plays out across the countries that you work in. The 4th perspective that we need to have is the economic perspective. So even as we look through all the services that we need to push, there's need to consider affordability. There's need to consider what we have to forego. So if we are picking malaria to treat, then we have to forego something else. And do we have to forego that, or do we need to increase the amount of resources available? Then the 2 is equity. We need to make sure that the most vulnerable populations are taken care of, and the opportunity costs as well in allocating all these resources and providing the services and interventions. So those perspectives play a significant role for all of us as we think about allocating and also mobilizing resources for health sector, and to think about it from those perspectives. But now to come to one of the key areas that I think becomes a very important piece for us to think about is what about SRHR? So SRHR, as a cornerstone of UHC, we have to think about what I talked about before, that the resources are limited, and we have to think about a rights-based approach to some of these essential services to the most vulnerable populations, and thinking more specifically around SRHR. And so if you are thinking about trade-offs, let's think about the how are we shaping the packages for SRHR. And I know there was a recent report that mentioned that that investing in a comprehensive package of SRHR services actually represents a very cost-effective bucket. And I know we're going to talk about that in terms of how we're doing that across the number of countries in our next presentation. And then always let's think about a progressive approach that begins on the essential services that target the women, the children, and the poor, and other vulnerable populations. So those are some of the things that we should be thinking about as members of parliament, and say, yes, we are driving UHC agenda, we are driving resource mobilizations, but where is it going to? How do we make sure that the vulnerable population, and also women and children, are taken care of, especially in areas of sexual reproductive health? So generally, in any context, especially in our countries that we support across the Southern African region, we always aim to, sort of drive a progressive move towards UHC by strengthening health systems, so that we can, at the very least, at the PHC level, that's the primary healthcare level, because a number of countries tend to sort of have a disproportionate allocation to hospitals. But if you look at the bigger chunk of a population, especially when you're talking about reproductive, maternal, and child health, over almost 75% of those services occur at the primary healthcare facilities. So those health centers, dispensaries, or health posts play a very significant role in driving some of these services. And so how we make sure that these funds going to the lower levels becomes important, because sometimes we get blinded by the hospitals in terms of the needs that they have, and forget that a significant chunk of actually results can be achieved by investing in preventative care, and more so at the primary care level or the community care level. So let's think about some of those interventions that we can drive down there. But even thinking about and what I want us to also think about as members of parliament, let's walk through a journey of a pregnant woman, and especially in our setting. So if you're looking at some of the countries, I know some of our work in Malawi, one of the challenges we're addressing is really teenage pregnancies. So how are we looking to, let's say, make sure that they have access to contraceptives as and when they need it, and what laws, and how are we locating resources to make sure that those commodities are available to make sure that is achieved? And so if we were to walk through a typical woman in any of the villages across the Southern African region, you see that mostly they come from homes that in most cases are poor, and mostly in some of them did not go to school or finish secondary school, right? So how do we think about them in terms of what sort of information they have access to, and how are we locating information, how are we locating resources to make sure they have information around the healthcare needs? And then the facilities are far, and I mentioned earlier that yes, you can remove the barriers at the facility level, but how do you make sure that they actually get there? So they walk long distances, or they have to incur costs in traveling, or also that's the day they'll miss going to the market, and that means they might not have money for the day in terms of upkeep for their families. And so let's think about it from that perspective. And then there are all these direct financial barriers that we have in facilities where they have to pay to seek to access care. So in most cases, you find in certain countries people paying up to like $2 or $3 to have access to ANC, and in most cases, most of them cannot afford. And so if we can drive as much investments to make sure that we don't present a barrier to them accessing care, I think that would be a fantastic sort of investment that we can think about as members of parliament. And finally, let's think about any barriers to accessing quality of service. And because part of this is around how do we make sure that the health workers are in place to do this, and what about the staffing? What about the infrastructure? What about the supplies? And what about the systems that drive some of this work to happen? Because in the end, all we want is to make sure that we avoid inequities in health and social outcomes as we drive some of this work. And so I think in this slide, what I want to demonstrate is there's a drive for us to sort of be very intentional in walking through the journey of every patient or every member of the population in the country and trying to see how we reduce these barriers. Yeah.
Sorry, we were losing you for a minute there. Not sure what happened. We lost you for about 3 seconds.
Okay, I'm so sorry. Maybe it's my connection, but I'm really sorry. So maybe I can. I think the last 3 seconds, what I was highlighting is the key thing that we need to think about is as we walk through the journey of any member of the population across our countries as members of parliament, let's think through what barriers do they face to access care all the way for them to achieve good health, and try to invest in those areas such that everyone has access to all the quality services that they deserve. That's the point I was trying to make. I'm sorry about the internet connection. So what are some of the work that we're doing across the region? And probably that would be helpful for members of parliament to know and probably take note of, is to achieve, especially to work with the manner, just what I've described earlier, is first of all, we have been very clear around how we define the benefits. So, and what's interesting, and especially a number of countries, is when you go to the health facilities, there's a big board written around the number of the services that you can access there. And so it's important that we continuously put in more money to expand that sort of benefit package for that. So we are also supporting a number of countries to mobilize resources. And I know I've highlighted that in terms of what we can do. We've done and what we continue to do across that. The other piece is improving resource management. And I'm going to maybe at some point talk about what we're doing across the number of countries in terms of resource mapping and expenditure tracking to just improve resource management. And finally, how do we make sure that we build the capacity of government to deliver some of these services, most importantly, to enhance knowledge sharing. And part of what I thank the SADC Parliamentary Forum for is providing a learning platform across countries, because every country has there are contextual differences, but there are certain commonalities across our countries because of population, and especially across the African continent, we tend to have a little bit more sort of closer and easily identifiable challenges that we can learn from each other without necessarily having to say we're going to up north to learn how some of these things can be done. Becomes important for us to create these knowledge exchange platforms. And one of the key things that I wish maybe the parliamentarians across the SADC region and more so the SADC PF is to build more of such knowledge sharing platforms. Not only within very specific areas of health, but generally just looking at health systems as a whole, so that we can reduce that resource gap to deliver the basic care, but also increase financial protection for households, and all this to sustainably finance care, so that all our countries, especially across East and Southern Africa, sustainably move towards the UHC goal. So I think I wish to maybe stop there for now and maybe invite this session. And I know I've mentioned quite a number of items that maybe generated some questions. So I wanted to leave a significant space for us to just maybe take some time and digest and maybe raise questions that you might have, and happy to answer those questions. If there's any sort of further information, I'm definitely happy to provide based on what I've said. So I'll pause there and maybe hand over back to the Honorable Chair to guide the question and answer session. Thank you.
Thank you very much, Dr. Rero, for such a resourceful presentation. And as you say, we are now going to open up the floor for members to make some remarks, to make comments, as well as ask questions. So the way we'll do it is, given that we have members online and both physically, We have members of parliament and other members of staff with different expertise in the gallery. We will open up opportunity for members of parliament to engage, after which then we'll open the floor for all the members who are present in the meeting to also have a chance to have some input. So, honorable members, the floor is open for comments, questions, and any remarks that you would want to make following the presentation from our resource person.
Yeah, thanks, Honorable Chair. I'd also like to request, in case there are questions from the French speaking or Portuguese, maybe I can have someone to translate the questions for me. Thank you.
Okay, thank you very much. We'll figure out how we get translated versions to you, because on our side we do have translation. There is translation online. Okay, it seems the technical team says there will be translation available to you. Okay, I see two questions from members, two hands from members from online. Honorable member from Angola. I see a hand from Vivian Joseph. So far, those are the two that I see. I would like to honor the hand from honorable member from Angola.
Muito obrigado, Sr. Presidente. Gostaria de felicitar o nosso preletor pela sua brilhante comunicação e tenho uma pergunta muito concreta. Os chefes de Estado haviam decidido em Abuja que o orçamento destinado à saúde deveria ser de 15%. Dos estudos que o doutor realizou, qual dos países tem estado a cumprir com essa percentagem? Muito obrigado.
Translate for me, please.
You get the translation regarding the Abuja declaration of 15%?
I don't think I can hear. I don't know whether someone is speaking because I can't hear.
Ronald, can you just explain what the
Dr. Riro, on the platform.
Dr. Riro,
Yeah.
Did you choose the language of your choice on interpretation?
I think I probably missed that.
He's speaking. I'm not sure what it is now. But I can't hear him too on my end.
Okay. Are you able to hear me now?
Yes, I can hear you, Dr.
But we
Riro.
can't hear him. Chair, maybe intervene.
Yeah, I can hear Dr. Riro from my side. Can you speak, Dr. Riro, so we confirm if the rest of the members can hear you?
Mr. Chair, I can hear you quite clearly, and I can hear Madam Secretary General. The translation, I'm not so sure whether I can hear it. So where is there a section that I'm able to view it, the translation?
Yes, Dr. Riro, if you look at on the platform, at the bottom of the screen, there is an icon that allows you to pick the language. It says interpretation. Then when you click on that, it allows you to choose the language to which you want the interpretation to come in.
Okay, good. So I've just done that.
So you have chosen English. So I'm going to ask the member from Angola to repeat the question. and then you can confirm with us if you are able to hear the translation on your side.
Okay, good. Let me wait. Okay, good.
Thank you very much. Honorable member from Angola, apologies for the technical issue. Would you kindly repeat the question for Dr. Ruro to be able to hear you so that he can provide response adequately?
Obrigada, senhor presidente. Com muito prazer, eu repito a questão. Eu dizia, em primeiro lugar, que gostaria de felicitar o nosso preletor pela sua brilhante comunicação e que queria colocar uma questão muito concreta. Existe um compromisso dos chefes de Estado que foi obtido em Abuja de que todos os países deveriam destinar 15% do orçamento para o setor da saúde. Dos estudos que o doutor tem estado a fazer, gostaria que mencionasse quais os países que já cumpriram com este compromisso. Esta é a questão muito concreta. Muito obrigado.
Very, very clear. And thanks again for the question. Mr. Chair, I don't know whether I need to go or I wait for more questions.
I would suggest maybe we take a bunch of 3 questions at a go, so that you respond to them all at once. I do realize we have a hand up from Vivian Joseph. And from what I see, I don't believe he's the member of parliament. Would you kindly give us a little bit of time to see if we have any deliberations from members of parliament, and I'll clearly come back to you again on that. Honorable members, I see a hand here from honorable member from Eswatini. Then I see honorable member from Zimbabwe. We'll take those 2, and then we can allow Dr. Ruro to respond to that, and then we'll have another batch of questions thereafter. Thank you.
Thank you, Honorable Chairperson. Chair, I just also want to add my voice in appreciating the quality of the presentation that we just received. Chair, it has been an eye-opener for us, and it gives us clarity in terms of what we need to do as members of parliament in dealing with issues of health financing and also supporting the agenda that we are here about. Chairperson, just looking at hearing the presentation, I think the one thing that stood out for me was the issue of digitization of the health system and making sure that we have a system that captures all the information about everyone that really is accessing health services throughout the health value chain. As the Kingdom of Eswatini, we are also in that journey, and we do believe that our health system, if we digitize it, it will not only help us to manage the stock levels of the medicine, but also it will help us to understand the quality of the people that are accessing the health services, and also to appreciate what the gaps are and how we can improve in terms of providing the much needed health access to all our citizens in the kingdom. Chair, I also do want to support what the honorable member from Angola asked. I do want to say in the Kingdom of Eswatini, we use the Abuja Declaration as part of what we benchmark on in terms of the guidelines. We also use the standards and the guidance from the World Health Organization in terms of how we distribute our budget at national level. So the Ministry of Finance, when they do the budgeting process, they make ensure that all these issues are taken into account. It is a journey for us as well as the kingdom, but I think with the gains that we have achieved so far, it is really about that. The other key learning from me, Chair, listening to this presentation, was that there has to be a good balance between self-financing and also getting support from donor funders. The Ministry of Health, in their report that they have been working on, really in Eswatini, it really projected the fact that with getting donor funders, sometimes the donor funders will bring in money that has conditions. So sometimes that digresses the country from its core mandate and the core direction that maybe the country is taking. So the balance that the presenter was presenting to say we need to have a good balance in terms of the donor funding and self-financing, I think that one will help us a lot to achieve all the objectives we so seek to achieve. I so submit, Chairperson. I thank you.
Thank you very much, Honorable Member from Eswatini, for your remarks. I just want to point that we have also identified and we want to acknowledge the hand from Caroline Kwamboga, who is online. We will surely come back to you again, just like we did mention with Vivian. We would like to give opportunity to members, honorable members. Honorable member from Zimbabwe, you had your hand up. That will be the last question in this batch. And then Dr. Riro will respond, and then we'll come back and open up another batch of questions. Thank you.
Thank you, Honorable Chair. I would like also to thank the presentation from our doctor. I think it's an eye-opener because I strongly feel that we must do a lot, especially in our countries. I was trying to figure out on the issue of the health expenditure especially on the capital expenditure. I was looking at South Africa and I realized that they use a lot of their fund from the government, which clearly tells us that we must have more of these initiatives so that we don't actually depend on donor funding. But my main worry is on the issues of teenager pregnancies, especially in our rural areas, even in the urban sector, taking into consideration the issue of the drug abuse, which is also another phenomena which is also contributing to all this issue of teenager pregnancies. And I was now asking the issue of the user fee. The doctor highlighted that some they spend about $2.50 per ANC, but I strongly feel that yes, in most of the countries, we say for antenatal care is free, but at the end, these people are also bearing a cost in terms of distance, in terms of transport cost, and also in terms of poverty, especially in our rural areas. And my question now is, maybe with his experiences, how can he try to give us more information on how best can we do on the issue of the user fee? If you say they are going to access their medical care for free, how is it comparing to our income as countries? Because it's more like, yes, it will be on paper to say they will access their health care free, but at the end, they're also bearing the cost. How feasible is it for the antenatal care to access them for free, and the subsidy will go for the government? And I just want to hear from him that is it possible? Is it possible? Because it can be on paper, but at the end, these people, they also pay transport, they also pay the health cards and some of these issues. Because if I also share with you that yes, it can be free, but when they access, like for those who go for cesarean section, they are also going to pay some of the cost. So the issue of saying they will be accessing it for free, it's not going to be like feasible. It will be yes on paper, but practically, I don't know how basic can he share with us on how are we supposed to do it vis-a-vis the income and vis-a-vis the expenditure. Thank you.
Thank you very much, Honorable Member from Zimbabwe. Dr. Rero, I would want to hand over to you to be able to respond to the three questions that we have. And then we'll open up another batch of questions and comments for honorable members. Thank you.
Thank you, Honorable Chair. So I wish to pick up from the question by the honorable member from Angola. And, you know, a very good question, and especially for us as members of parliament. The Abuja Declaration of, which is about 20 years now since this declaration was made in 2002, was to allocate that all governments must commit, all African governments must commit about 15% of their budget to the health sector. Very few countries have even come close to the 15%. So what role, because most cases as members of parliament, especially around allocating resources to the health sector, is let's also go back to the international commitments that our governments have made. Either they made a commitment in the Lusaka Accord or Astana Accord. There are all these things that our governments do sign. How do we hold them accountable? And so what I must say is most of them have not, but we must drive towards helping them to work towards that. I know a number of them will say, oh yeah, but we're allocating in food. Food that has an implication in terms of health, we are allocating agriculture, which is a fair point as well. But let's, as much as possible, try to move towards that direction. The second question from the honorable member from Eswatini. So I fully agree with you in terms of digitization. So digitization is one driver of efficiency and one of the drivers which we can actually, drive some of the quality of care and also expand health sector investments. And that I fully agree, and that cannot be understated. And I think as members of parliament, one of the things that we should push as a mechanism of delivering care is also digitization, because it plays a different roles. Part of it is there is all conversations around telemedicine. So how can we, from a distance without having to people travel, actually receive care through teleconsultation without necessarily having to travel? Or how can they make sure that if I received care from facility B, when I travel to go to facility C, actually my records are already there. I don't have to redo the tests. I don't have to do the new X-ray or MRI. I'll find my tests there. So that becomes an important thing to do. And again, I fully agree. You also touched on Abuja Declaration. I think if there's anything to come out of this as members of parliament, is let's reflect around how we can push our governments to move towards a fulfillment of the Abuja Declaration of 2001. And then lastly, the honorable member from Zimbabwe. Teenage pregnancy, I think, in a number of countries, this is really a bigger challenge to us. And also have to, especially when you're here, you have to imagine that it goes beyond health, it goes also to education. So how are we shaping the relationship between health sector and the education sector, especially in terms of creating awareness, not only awareness, but even access to, let's say, sexual education, contraceptives, and all that for teenagers, and even sexual counseling and all these other counseling mechanisms that we have availed from the health sector to the both to the health sector and the education sector. So that becomes an important. And finally, the question on user fees. So they are, I think, user fee conversation is especially very complex in a number of countries because yes, you can remove the user fee, but the problem that a number of countries face is, yes, I don't pay, but when I go, the service is not there. But so we have to do a balance of, let's not just say, yes, we have removed user fees, let's also avail the service. But what are other countries doing to navigate through the removal of user fees? So I'll give you an example of the country that I am in right now, in Kenya. What happened is a whole package. The government set aside money for free maternity services through the National Health Insurance Fund. And so for every ANC visit, the health facility receives money on behalf of the mother. So you don't have to pay, but the facility actually receives the money. When you deliver, and this is agnostic of whether it's a private facility or a public facility. When you deliver through a cesarean section, there is a money for it. And normal delivery, there's money for it. So we can set aside resources that can actually provide these services on behalf of the mothers without necessarily them having to pay. But also, as you said, it's not enough that we've told them that they'll not pay at the point of care. They need to travel to point A, to the hospital. And so what a number of countries are doing is to make sure that we have, one intervention is, let's build more health facilities closer to the people so that people don't have to travel longer distances to access these services. But most importantly, let's think of other mechanisms such as community health workers or community extension workers and all that to reach the mothers to provide those services where they are without necessarily having them to travel. So we either bring the services, so we have to work towards bringing services closer, either infrastructure or even getting the community health workers closer to the mothers for them to be able to offset those kind of costs. Over.
Thank you very much, Dr. Rino, for such a response. Just want to check with the members who have been responded to, if there are any follow-up questions or if you were sufficiently responded to. And I would request that this should not be new questions. It should just be a reaction to the response that was given so that we are able to move on to other members. It should not be a totally new question. Okay. At this point in time, I think Dr. Ruro, they are happy with the response. I'm going to open up another batch of questions, after which then we will consider other members who are with us online, who are not necessarily honorable members. I see honorable member from Madagascar will have a question. If no other member will, our honorable member from Malawi will also want to have an intervention. I will also love to have an intervention as honorable member from Lesotho. Honorable member of Madagascar, the floor is yours. Thank you.
Merci, Monsieur le Président, de m'avoir donné la parole. J'aimerais féliciter Monsieur le Docteur Riro qui vient d'expliquer le cours accéléré de l'économie de la santé. Et d'après le tableau que nous voyons tout à l'heure, on ne voit pas le cas de Madagascar. Donc, j'aimerais poser la question, est-ce que ça va intervenir aussi chez nous? Parce que ça ne figure même pas dans l'image qu'on a projetée tout à l'heure. De deux, avec la pertinence des analyses que Dr. Riro a fait sur le système de santé, il a stipulé l'ODD 3. J'aimerais insister sur la couverture sanitaire universelle, mais ça n'arrive pas maintenant. Donc, j'aimerais insister sur l'existence de case qui va nous aider à améliorer l'implantation de couverture sanitaire universelle chez nous.
Communication with the meeting.
I don't know if someone is still talking because I can't hear.
We have lost communication with the meeting.
Oh, okay.
Yeah, we've lost communication completely. So technical guys are trying to figure it out.
Okay, okay, good. I was
I hope
wondering whether
somebody
it's my
can. Yeah, okay, thanks.
Good, thank you.
Apparently, there's a power outage in South Africa. So maybe we just have to wait a bit and see what happens.
Hello. This one. Honorable members. Yeah, put this on off. Thank you. Honorable members, I would like to apologize for that slight technical issue. We were disconnected from the Wi-Fi. I would like, before we proceed, for you all to confirm that you can hear us. Madam SG, Dr. Ruro, can you hear us?
Yes, we can hear.
Okay.
Yes, we can hear you. Thank you.
The chair is not there anymore.
Madam SG, we were trying to sort an echo that was around us here on the chair table. We would like to give an opportunity again that the member from Madagascar who got cut off by the network. Dr. Ruro, you had some portion of the comments from the member. Kindly talk a little bit back, honorable member, so that whatever he may have missed, he can be able to capture. Thank you.
Merci, Monsieur le Président. J'aimerais répéter mon intervention tout à l'heure. J'aimerais aussi féliciter Dr. Riro qui fait des cours accélérés sur l'économie de la santé et il nous explique vraiment et fait l'analyse du système de santé. Mais comme je vois tout à l'heure, Madagascar ne figure même pas dans les tableaux qu'on a projetés tout à l'heure. Mais nous faisons de partie de faibles revenus. Donc, on a vraiment besoin de baseline à partir des analyses que l'expert a fait comme tout à l'heure. Mon intervention, ça consiste vraiment sur le CSU, parce que là, on essaie d'implanter la couverture de santé universelle chez nous, à Madagascar, mais ça ne démarre même pas jusqu'à maintenant. Donc, nous insistons surtout sur l'existence de plateformes d'essence au sein de notre organisation qui nous permet d'améliorer, de prendre des initiatives pour faire marcher notre couverture sanitaire universelle. Et il a bien expliqué que l'importance d'intervention sur le SDSR, la santé familiale et l'existence aussi de rubriques qui concernent sur le lutte contre les maladies, les frontières sanitaires et surtout dans les santé sexuelle et reproductive. Donc, nous aimerons avoir des appuis, surtout pour faire démarrer notre CSU à Madagascar. Merci.
Thank you very much, Honorable Member from Madagascar. I hope Dr. Riro was able to capture your intervention. I do realize that there is a member from Namibia who would like to come. I would therefore forfeit my. Oh, there is Malawi, sorry. Malawi will come after Madagascar. Then instead of Lesotho, then we will have Honorable Member from Namibia, and Lesotho will come in the next batch of questions. Thank you.
Thank you very much, Honorable Chair. And thank you very much, Dr. Liro, for your good presentation. My question is very short. I have an issue with the Abuja Declaration 2001 on the 15% of the total national budget. I have in mind Malawi, where 15% of our national budget will only be able to cover about half of the total cost of the whole healthy care. Now, my question is, what could be the best way of allocating finances to healthy care above the Abuja Declaration? Because most of the countries are fighting just to attain the 15% Abuja Declaration, which leave gaps on the healthy care financing. Thank you very much, Honorable Chair.
Thank you very much, Honorable from Malawi. There's Honorable Leonard from Malawi. Thank you for your intervention. I'm going to give an opportunity to Honorable Agnes Kafala from Namibia.
Thank you very much, Honorable Chair. I would like also to thank Dr. Riro for the well presented interaction. However, I would like to just find out as to the research for the countries presented. I would like to find out exactly whether all the countries in SADC region were researched, and if so, how did you only arrive at those that are doing better, and we seems to leave out the one that are lagging behind? And for that reason is that perhaps we need to also get some assistance for those that are a bit lagging behind. The other one is on the Abuja Declaration on the 15% for the countries to reach that mark. And for Namibia, we are shortly falls with 13% currently. And I think this reflects a strong government commitment to health sector. And we we are here to learn and also to understand as to where we should improve for us to be able to reach the target as some of us assigned to make sure that we have reached the target of all that we have set up for ourselves. I thank you.
Thank you very much, Honorable Kafula from Namibia. That makes up a bunch of 3 questions that we would like you, Dr. Rero, to be able to respond to. And then we will get back again to try to find additional more questions, which will then offer an opportunity also to the members in the gallery to be able to intervene. Thank you. Dr. Rero, over to you.
Thank you. And again, I think there's some echo that is coming from the other end. I don't know why. Okay, good. So Madagascar, the honorable member of Madagascar, thank you for your question. I know there was an interruption, especially when the power went off. So I might have missed some sections because even the interpreter came in late. But I think I got a couple of things from your end. First of all, the question that I have to answer is, I mean, it would be great. We don't have an office in Madagascar. We'll be happy to. I think it's something that we'll be keen to work in Madagascar to support the health system in Madagascar largely. So it's one of those things that happy to talk through and see how we can partner with Madagascar, the government of Madagascar, to support them towards especially some of the reforms that I've talked about. So I just thought it's an area that I first address. The second point that you asked around, the rising cost of care, how do countries then balance between that? So there are a couple of interventions that other countries are having to address the rising cost of care. So one of the things is identifying what is causing the care to rise. One of the key things is that we're getting commodities, all of them are imported. So if you're looking for medicines, if you're looking for equipment, all of them are imported. So a lot of countries in the continent are thinking about local manufacturing as one of the elements of cutting down the costs of care so that we can afford with the money that we do have. But again, it involves a lot of investment. It goes beyond the health sector, but also even talking about the Ministry of Trade and Industry. How do we drive local manufacturing? How do parliamentarians also interact with the other ministries to drive such kind of thing? Or even logistics, or even taxes. How do we talk about, I know a lot of countries are talking about zero rating, or they have zero rated a number of medical products. So how we are actually intentional around that becomes also important to do. The other question on even driving down to the community level is one of the approaches we can lower the cost so that we avoid people going to the high level facilities, because if we go to high level facilities, the cost is more expensive other than keeping them in the lower facilities, and also investing more in prevention than waiting for them to be sick. And so as parliamentarians, let's think about laws that drive towards investing more in prevention than waiting for people to get sick for them to come to hospitals. Malawi, and I fully agree. So the honorable member for Malawi, I fully agree. What I have to acknowledge is the Abuja Declaration was a number that was arrived at to just give countries a target or to rally people to put money in the health sector. But it's not a magic bullet. In itself, it's not that when you put money, you put 15%, then you go home and just sit and sleep. There is a little bit more that needs to be done. And part of that is, yes, we put in money, even the 15%. Where are you putting it? How are you being accountable? Where are the other bits and pieces that go with that money? And how is also shaping the other parts of the health system to make sure that this is responsive? So it's about how we have to do that balance on allocation. And I'm going to talk about that later after the break on allocation and spending. There is one thing to mobilize, but there's a whole conversation around spending, allocation and spending that I'm going to talk about next. Namibia, the honorable member for Namibia, absolutely. Namibia is one of the countries in Africa that is very close to the 15%, quite doing well in terms of the per capita allocation. I also have to say that the data I present is just select number of countries there is data across all the countries, and happy to share that in terms of how all these countries play. But it's just a selection of countries across the continent, just to give an example of how that is. It's not that other countries are left out in this research. All of the countries, there is this data, and happy to share that maybe with, I'll share that with the Secretariat, all the information. I just selected just the 5, about 6 of them, just to show the kind of spread, how that looks like. So happy to share that with you as well. So thanks. I think I'll stop there and maybe hand over back to the chair.
Okay, thank you very much, Dr. Rero. At this point, would like to call upon any other members that may have questions. Otherwise, I will give out the opportunity back to the members in the gallery who had ever indicated interest to intervene. I would really recommend, for the sake of progress and time, that we do not ask too many questions. So we try to make sure that our questions are, precise and don't take too long. We go straight to the point for Dr. Ruro to be able to respond quickly. I do see honorable member from Zimbabwe with an intention to the question. After which, then I will open an opportunity for the member by the name of Vivian, who is online, and also Caroline Komboga.
Thank you, Mr. Chair. Just to have it's not a question as such, but maybe if you can have the presentation so that we can also go and also make use of it in our countries. Then the second one is, Mr. Chair, because this is a very, very important presentation which we have already received, but obviously we cannot go and try maybe to give this to our parliaments. Maybe with his experience, whether is it possible for the foundation to link and do capacity building to parliamentarians so that members of parliament are capacitated to do budget tracking and resource mobilization from a legislative perspective. It is just something which I feel maybe to make use of our parliaments to have a resource mobilization. Thank you.
Thank you very much. I hope Dr. Rilo picked that. I will now give an opportunity. I realize that Madam Secretary General also has a hand up. So for this session, we'll have 4 interventions to pick. Vivian, the floor is yours, then followed by Caroline, and then we'll have Madam SG included in that batch as well. Thank you.
Chair, if you may allow me, I please come first to give context.
Okay. Thank you, Madam SG.
Yes.
The floor is yours.
Thank you very much, Dr. Riro. Let me join the honorable members for congratulating you for a well thought out presentation, which is quite informative and very practical. Honorable Chair, according to the concept note that we have, you will note that contrary to most of the concept notes that we do, we have highlighted that it's an expert witness session, which also means that we have citizens in the gallery. The citizens are going to add value to what Dr. Riro is saying and not necessarily ask him questions that are pointed. So for instance, there are issues that he's raising, and they will also give a lived experience or give much more insight so that it is not a matter of what Chai or Dr. Riro says, but also the practical realities of citizens in the SADC. Chair, I just needed to point this out because all other committees, if you will note the program, will be having public hearings. But we started this committee with a capacity development session embedded in it so that members are able to engage with the context of how citizens are raising issues. I just needed to raise this, Chair, so that it is not an anomaly in terms of why citizens are in the gallery and they're raising their hands. It doesn't mean Dr. Riro will not continue with his interventions. It just means that it gives weight to what he's talking about so that practically, when we raise issues of inequalities or iniquity, we are hearing from both ends. Thank you, Chair.
Thank you very much, Madam SG, for that context. It just makes it much clearer and makes us understand really what the interaction is about. So I'm going to open up interventions from the gallery, the comments. And as I mentioned, we had Vivian, and then we have Caroline. Can you come in that order, please? Thank you so much.
Oh, thank you very much. I had already put my comment on the chat box, but I will appreciate to also share it. Your Excellency,
Chair,
ladies and
I do not
gentlemen.
see Vivian online.
I'm here,
Is
ma'am.
she there?
Yeah, I think she's speaking.
Yeah, he's
I'm not
talking.
sure. Yeah,
Oh,
she's talking now. Yes, thank
He's
you.
talking, but we can't see the video.
Oh, and I can't hear on my end. Let me see what I need to do.
Okay,
Okay.
thank you. Please continue, Vivian.
Can you see me now?
Yes, we can.
Okay. Greetings, Your Excellency, leaders. I hope all protocols observed. I just quickly wanted to share and ask on the relevance of the implementation of the agenda into the Abuja Declaration, because even with countries, for example, most of the SADC countries, specifically Tanzania, has not yet met, apologies for the noise, has not yet met the standards of what was set to be done. And another thing is, it is only by 1% the ministries of health have received funds compared to the 15% that was promised to be met. But also, it is essential and important to also realize that with regards to the implementation, how practical is it in terms of the budget allocation to the SRHR projects? Very apologies to the noise that you've all heard background. Thank you.
Thank you very much, Madam, for intervention. I would now give an opportunity for Caroline Kombogo to also have their contribution. Thank you.
Thank you very much, Honorable Chair, for the opportunity. Honorable Chair, members, distinguished ladies and gentlemen, allow me to make a comment and add perspective into the conversation from the gallery. And my comment is specifically, just contextualized around the reality of the citizens' circumstances and the hardship that is experienced by citizens, or it is the basis that is accelerating the journey into deeper extremities in poverty. And the poverty is being accelerated because the health costs are simply, they are prohibitive, and they are really a major barrier to enabling access to essential health services. Now, having said that, it is important for us to really note that while the Abuja Declaration, the Astana provisions, and all the global declarations that have been made are really a yardstick. They provide a yardstick against which allocations can be made. There are other propositions that have come in to add or to really manage the realities that we face at national level due to budget limitations. And in this case, I really would like to highlight, one, the issue of parliamentarians' role while playing their oversight role to ensure that ministries or different levels of the budget cycle actually are guided by proactive or reviewed health financing strategies. This is one thing that the parliamentarians can really support to do. We also have good experiences, across the continent where community and health insurance schemes have come in to provide, consistent contributions into a pool, and the management of that pool mechanisms enables better access so that those who have a little bit more are able to contribute a little bit more and ensure that those who are most impoverished are secured. So this is within the framework of advancing protection or health protection to our citizens within an insurance framework, which could be national or community-based, because both models have been utilized, and they are really enabling for our citizens to access primary health care. So this is very important. And at the primary health care level, the limit should, or the reality should not necessarily be based on facilities in terms of infrastructure, but rather the service. So the emphasis should be on the access of service at primary health care level. So that is something that I wanted to also add onto the table for consideration. But even outside the box, there is also one other element that I would like to bring for consideration to the honorable members. And these are issues of debt restructuring, that sometimes there are other macro factors that are accelerating poverty at macro level. And there needs to be mechanisms that are discussed at parliamentarian level that can enable further restructuring of these debts, so that national liquidity is assured and secured to meet citizens' needs that are as basic as securing health financing, not just for accessing health, but ensuring that we don't push our citizens further into poverty because they need to access health. I submit and I thank you.
Thank you very much, Caroline, for that passionate submission. We are looking to break out for tea break at 11. So we do have 7 minutes for the reaction from Dr. Rero. And I would like to take an opportunity for this to have a few questions that I prepared from my side, given that most of the interventions we just received were not more of questions, but were more of emphasis on the presentation that you've already made. So I have 2 questions that I would want to put before you, Dr. Rero. Really to say, based on the evidence, the empirical evidence that CHAI might have had across the countries where it operates around issues of health financing, what are some of the strategies that have been implemented in some countries on increasing domestic funding for healthcare? Either being tax strategies, taxation policies. Have you witnessed any that have actually worked in any of the countries across Africa where they were able to create a larger pool for health financing domestically? I'm asking this because if we look at issues around health, there are some commodities that could be considered as luxury commodities, such as alcohol and tobacco, which possibly we could introduce the levies or taxation on such products, and then the tax that would be collected from that could then be directed into health spending. Has any country done something of that sort, or even if it's a different product, not specifically to this one? I'm just mentioning tobacco and alcohol because we do know their contribution into the deterioration of health of the citizens and everything. So that could be used as a justification to say, if we are going to consume the products that will end up leading to high health expenditure, then we are going to be taxing those products and be able to have a pool of resources to be able to respond to health situations. That's my first question. The second question, really, while talking about the perspectives, the different perspectives that we look at when we talk about universal health coverage, the legal perspective, what has been one of the game-changing legislative instruments that you have witnessed in other countries that really targeted issue of health financing? Because we are here, we are speaking about this. At the end of the day, we really want to come up with some, concrete recommendations that we are going to be making to the SADC plenary, which will then maybe possibly translate into some model laws that could end up in our countries for domestication. Has there have been any legislative breakthrough from any of the countries that tried to address the issue of health financing? And if there is any, would you kindly share? Thank you very much. Those are my questions. The platform back to you, Dr. Rero. And then after your responses, we'll gladly break out for tea and come back for the second session. Thank you.
Thanks, Honorable Chair. And questions were received. I wish maybe to step back a bit just to amplify some of the comments given. So the member of parliament from Zimbabwe, definitely happy to, together working with the SADC PF Secretariat. I mean, there's an opportunity to try and explore how we can do this at parliamentary level, at national level, to drive this. And as again I mentioned, especially for Zimbabwe or most of the countries across the SADC region, we have our offices within that. So happy to work with our country offices to do that at parliamentary level, and especially working through the SADC PF. So happy to do that. Vivian, I think that was more. Yes. Hello. Hello, can you hear me?
We can hear you. I'm not sure if the room can hear you, if the chair can hear you, but I can hear you.
I can see the chair is sort of, I don't think their audio is working or something, because they're
Yeah, I
not
think
moving.
he looks frozen. Yeah,
Looks
he
frozen,
looks
yeah.
frozen. Yeah. Maybe it's about time they go for tea, that we respond when they come back.
Clearly, I'm happy to do that as well. Maybe
Yeah.
we can ask them that we can take a break, then I respond as I start the next presentation.
Okay, I think so, because I think some of the issues will also come up in your presentation after
Absolutely,
that. Yeah.
Okay.
Dr. Reddy, we were kicked out by network. We are back. Would you currently confirm if you can hear us?
Yeah, I
Chair,
can
is
hear
it
you
not
quite
perhaps
clearly.
that you go for tea and then come back so that some of the responses can be given? And then some of the answers are also in the next presentation, if it's okay with,
Yes.
yeah.
Okay. Okay. Thank you very much, Manji. I think I heard the last part where I think you're recommending that we break out for tea break, and then when we come back, we can then have a few minutes just to wrap up the previous presentation before we move on to the second one. Did I hear you right?
It's continuous, the presentation. There will be no harm if you went for tea, came back,
Yes.
and we continued with responding,
Continued.
also continuing, if that
Okay.
pleases the chair.
Thank you very much, Madam SG. That would work for us. Honorable members, at this point in time, we'll break out for tea break. It is 11 o'clock as per my watch. Back into the room again at 11:30. Thank you very much.
Good.
Thank you, Chair. Thank you.
Sim. Uhum. Hum.
Não,
Ah, tá bem, ok.
Honorable members, I think we are all back. For those who are physically with us here in Johannesburg, we'll be calling the meeting to order in the next 2 minutes. Thank you. Yes, by my time, I think we have reached at the time we agreed to come back from tea break. Welcome back, honorable members. I would like to get back to Dr. Riro, who was still on the platform responding to the questions and interventions from honorable members. And then after which, Dr. Riro will continue with his presentation, where he will now be speaking to the allocation and spending of resources efficiently in health system, continuing to highlight the role that members of parliament can play in ensuring that. Dr. Hero, if you're ready, the platform is yours to continue where we left. Thank you very much.
Good. Thank you, Honorable Chair, and really happy to have me here. I wish maybe everyone could mute so that I don't get an echo.
Now, the members would we kindly mute our mics, especially for those who are online. Thank you.
Okay. Thank you. So I wanted to pick up from, I don't know why I still get an echo. Maybe the technical team, you can look. Is there something I need to do?
I think Maria Gomez, the mic is not muted. Just as one of the members I can see on my side.
Maria, are you there?
Your mic is not muted.
Maybe the tech team can mute her.
Yes, please. That on the platform, would you kindly help to mute all members who are not speaking?
Okay.
Let us try it again, Dr. Rido, and see if we're okay. Dr. Rido?
Good. Maybe you can also mute from your end, Mr. Chair, and see whether it works best.
Dr. Rido, can we proceed and then see if we still have an issue?
Yeah, let me proceed, but I can still hear myself. I don't know whether I need to leave then come back or something.
Can we? Yeah, it is the tech team says that should be from your end. Would you kindly check on your laptop the volume for your laptop? We could put it off.
Let me try and use the headphones and see whether it will improve.
Okay, thank you.
Can you hear me?
Yes, we can hear you.
Okay, good. I think I can work with this. Good. So I just wanted to answer the initial questions, especially what the Honorable Chair you had raised. Are you able to hear me?
Yes, affirmative. We can hear you.
Okay,
Yeah, we
good.
can hear you.
Fantastic. So I wish to just quickly answer the question that the Honorable Chair you had asked on, what are some of the interventions practical interventions that countries can use to raise resources, especially domestic resources. And what has happened across Africa and what can we work with? So if you go to, let's say, Ghana, so what Ghana did was to set aside 2% of their VAT. So for example, if your VAT is, let's say, 14, you literally raise it to 16 and take that 2 and commit to help. And so that has been one of the approaches that other countries are using. But you just have to be clear that this 2% that you're selecting is not being allocated to anything. You just earmark and say that this is for help. And I think that has been achieved in Ghana. If we go to a country like Gabon, they have taken 10% of their calling, their airtime, let's say what you call on mobile phone, and dedicated to help. So that could be one of the approaches that we could learn from those countries. Let's come, when it comes down to East Africa, Rwanda has very many other ways in which they're raising resources. A lot of people know the community health insurance as one of the approaches, but actually there are many more ways that they're raising the funds. So if you look at traffic fines, so traffic offenses, the fines take to help. They're taken to help. So you have to think about which other fines are there in the country, how can we channel that to the country? And even the fuel, when you fuel your car, there's an amount of money that goes to help from Rwanda. So that's one of the interesting things that can think about. Just to mention a few, because a number of countries are using different approaches to raise that. But in terms of seed taxes, what you raised in alcohol, sugar, or salt, because they have an impact in terms of our health, right? So if you're looking at, a lot of countries are actually, raising taxes on seed taxes, on those alcohol or sugar and all that. But the bigger challenge is, are we being clear on where that money is being spent? Because it's another thing saying we are taking the money from
from these schemes that have an impact on health. But is it actually earmarked for health? So what parliamentarians can do is, yes, we are raising taxes on alcohol, but is there a way in which you can take a proportion of it to health and not necessarily just raising funds? Maybe, I mean, to be good if there can be roads and all that because of impact on health, but is there a section of those taxes on alcohol or sugar or beverages and all that can be earmarked for health? So that is an interesting bit. A lot of countries are having all these sort of what you're calling sin taxes, but very few are actually earmarking for health. But it's an interesting thing that we can have a talk about this. Maybe, and I'll talk about that when we talk allocation later. The next question that you asked, which was very interesting, is around what are some of the legislative interventions that a number of countries in the continent are driving to change this. And let me go back to even the SADC region. I know recently, about maybe 5 or so years ago, when Zambia brought on board the National Health Insurance Management Agency, what they're calling NIMA, it was one way of saying, yes, we've been doing this through taxes, but can we set a mechanism that sets a national health insurance that can actually now mobilize resources from the employer, the employee, to bring resources? I know the team in Eswatini are also on course in terms of trying to think about a way of setting up a national health insurance. South Africa just recently, signed into law the national health insurance. So if you're looking at that, it's a drive by Parliament to drive sort of a mechanism which we can have a prepaid way of people putting in money to raise resources domestically to raise towards that. The other bit that a number of countries are working on the legislation is a private-public partnerships. So, because it's not enough that we just focus on public funds, it's also another way of seeing how can the private sector and the public sector relate, and a legislation around enhancing private-public partnership laws in every country, in a number of countries that is happening. I'm happy to talk about that. So there are quite a number, but I'm happy to address that as they come around questions. So I wish maybe to proceed with the rest of the presentation, just in case there's something that I mentioned earlier, we can also build that at the end of this presentation. I know we probably don't have as much time as early in the morning, and this section is essentially building on part of the questions that are part of the issues that are raised earlier. So if you find any repetition, it's just a sign of emphasis, especially when we talk about allocate. Because the continuum really is, let's mobilize the resources. But the other bit is, as we mobilize the resources, let's allocate those resources appropriately, but also let's spend efficiently. So it's not enough to just raise the resources. As I said, we can raise 15% of Abuja declaration, but if we are not allocating it well and spending it well, we are not achieving much.
Dr. Ruru?
Yes.
Yeah, we've been experiencing the technical issue really. The interpreters are saying they can't hear you quite well. And this is after we used the earphones. They're requesting if we can try again without the earphones so that we see if there is an improvement.
Okay, let me remove the earphones and see whether that works. Actually, I've realized even the echo has gone off, so I think I can work with this.
Can hear it clearly from our side, and this is what we want to hear.
Okay, good. Can you hear me now?
Yes, we hear you very well.
Okay, good. So I think I can work with this. So maybe I was building from that as we, earlier in the morning, we talked about raising resources or mobilizing resources. And I was saying it's not enough that we raise resources, even as Parliament, that's a fantastic, and it's your role around how we can, we can push for raising resources. And I know Caroline mentioned some of the macro issues that we deal with around debt restructuring as a way of just freeing up the fiscal space for more resources to be allocated towards health, because a number of our countries across the continent, a larger chunk of the revenue is being used to service their debt, which essentially means there's less left for social services such as health. And so how we do debt restructuring, or even how we manage debt within the country as parliamentarians, has a direct correlation with how much of the resources are available for health. And so once we talk about the resources being availed, the next bit that we talk about is how do we allocate? And to allocate resources, there are a couple of things you have to think about. Today, it's about prioritization, and it's also trying to see where do we put money, where we get the most out of it. And the next one is, once we allocate, then we need to spend. How do we spend that? And so allocation and spend as part of the continuum of health financing is what I'm going to talk about next. So back to, our some of the bits and pieces that I mentioned. So just to emphasize, especially why it's important to think about once you allocate, once you raise resources, let's think about how we allocate and spend. So the first element is, let's prioritize services. So let's, at the very least, think about services that can be reliably delivered and financed to the populations that are in the greatest need, and then continuously expand that over time. So starting small, but even that small, you're thinking about the populations that we're addressing and the needs that they do have, and then we expand that over time. And so that becomes a very interesting way of, first of all, as Parliament, pushing towards certain, even as we talk about health being a right, let's imagine which services that the population need and actually advocate for that as members of Parliament that are tasked with driving resource allocation. Once we've done that, let's at very least shift away from out-of-pocket spending. And this is, so at every point, let's try and put laws that shift from out-of-pocket expenditure, user fees at the point of service delivery, and put mechanisms that pull resources together to purchase care on behalf of the population, instead of having themselves to only access care as and when they're able to afford it. And the other bit is just redistribute the resources. So what we need to do is make sure that we have a fund or a set of resources that ensure that, there's a cross-subsidization. What do I mean by cross-subsidization? That it also has a mix of the rich and the poor, the healthy and the sick, or the young and the old, even as we shape our national health insurances. And at that I'm mentioning the countries that are thinking to work in that direction. It's not intuitive for us to think about, let's create a national health insurance only for the poor, only for the rich, or only for the young, or only for the old. We must come up with a mix of a lot of them so that we're able to cross-subsidize the risk that they do have. Then the next thing that we need to think about, especially the allocation and spend, is let's link payments to need or outputs. So it's not enough that we pour money into the system. Let's also keep thinking about what are we getting out of it, and in terms of, are we getting value for money? So let's pay providers or health facilities or the system, depending on what we're getting in terms of output. So in terms of services or visits or etc., to increase the value for money. And finally, as we think about the allocation and spend, let's think about building strong institutions. So if you're thinking about an insurance agency, let's think about a stronger institution that has capacity to manage those funds efficiently, equitably, and transparently. And those are the things that we should always be thinking about, that yes, we have mobilized resources, but let's also build strong institutions that are able to purchase care. And these are institutions that we should shape them to be more efficient and equitable, as well as transparent. So I mentioned a bit around health benefits package, and this is something that continuously comes up. So even as we decide, yes, there are resources, where are we spending it on, or where are you allocating to? We must think about a set of services. And so what is the role of Parliament, especially in deciding some of this? It's around, yes, let's say, for example, we are deciding sexual reproductive health or maternal health, or in whichever form. What our priority are they, and are we making sure that all services are actually provided without any sort of hindrances? If we're thinking of child health, let's think about issues around immunization. And so do we actually have resources dedicated for immunization at the very least, so that we keep some of these interventions accessible to young children? And then we should be clear around what services are available and make that be very clear to the public, because it's not enough that we've defined this at high level, but the public also knows what they're entitled to. So that sort of entitlement, aware of what they're entitled to, also helps them to advocate and actually drive providers to provide quality care. But also being quite clear that there's a trade-off. around all these things. As I mentioned earlier in the UHC Cube, when you give this, you have to think about what else you have to give up that enable resources to be allocated efficiently. So the other bit that we have to think about is, let's always think about quantifying the supply side gaps. So supply side gaps, I mean, what at provider level do we have? What are the gaps? And then we start filling them. And so we as representatives of the people, then we should be looking at, if at all there are no facilities or infrastructure, what sort of investments could that be? And if at all there are people that are having to travel long distances, how can we make sure that these facilities are closer to the people? And I like to what one of the contributors, the commenters from the gallery talked about, that sometimes when you're talking about health services, we're not talking about infrastructure. We're talking about just what people have access to. Some part of this could be community health workers, or it could even be how we structure things like telemedicine or other digital approaches to making them have access. So we're not talking about health facilities as a hallmark of everything, but is what mechanisms put in place for people to access the service, not only just to access the facilities. So, there are a couple of things that we have to think about. We have to make sure that all that we're doing in terms of shaping the benefits package is explicit, that mainly it's out there and everyone knows, so that you don't keep some of these elements not really clear to the public. And I think advocates that are part of the gallery, this becomes an interesting one, that how do we hold governments accountable, how do we hold parliament and other actors to make sure that the service entitlements across the population is clearly outlined and the population knows what they're entitled to when they go to facilities. So what are the practical examples when we're talking about all this? Maybe to walk down, especially trying to highlight 2 or 3 countries within the region, and happy again to see how we can drive that conversation afterwards. So let me pick with Malawi, maybe to build up from there. Is one of the things that I'm happy that we have members of parliament from Malawi, and probably at some point happy to hear your contribution as well around the thinking. Malawi is one of the countries that are, especially across the SADC region, that has a high proportion of their health expenditure or their resources for health coming from external funds, so the donor funds. And so what that means is it's quite fragmented. So, if the US government or through USAID or CDC are bringing in funds, it's a whole different basket. If FCDO or the British government is bringing money, then it comes a different basket. If World Bank and other entities are coming in, so they come Global Fund, Gavi, GFF, all these come in different buckets. So what fragmentation does is there's potential for duplication. And once you duplicate, then inefficiency comes in. So you'll find there is no coordination around how some of these things happen. And so we, as a team in Chai, what we've been very keen to do in Malawi is largely to drive resource aid, so what we call aid coordination. How do we do resource mapping and expenditure tracking of different revenue streams to make the government quite clear and have visibility around where the money is coming from, where there are possible ways in which they can avoid duplication. So as Parliament, what will be important for us to do then is to push for laws that clearly ask for accountability from donor partners in terms of being explicit around the funds coming in and what they're actually going to do to get this done. The other bit that we've been very intentional about, and happy to hear, happy at some point if there are any questions around this, is, especially for Malawi, there are about maybe 50 strategic plans for the different diseases. So you find there's a malaria strategic plan, there's a TB strategic plan, there's every bit. So there are many plans, but they're not talking to each other. Because if you're investing in all these plans, if you're not talking to each other, then it becomes a whole complex issue. So our work in Malawi has been what we are calling a one plan, one budget, one report. And so driving towards a more coherent plan or strategic plans in the health sector that can speak to each other without necessarily having the 50 plans that do not speak to each other, and hence leading to confusion, especially around how resources are geared to. And so the one plan, one budget, one report becomes one of the things that we as parliamentarians should always advocate for in terms of efficient utilization of resources. But happy to talk that more just in case there are any questions around that. So what are these? What does this do then, especially just still on the Malawi case? What challenges does it pose? So we have fragmented funding, which complicates resource allocation. And part of this, how does it do? There is a limited flexibility to adjust how resources are used, especially because each of the donors come with just priorities that they're looking at without necessarily going back to the Malawian government or the people of Malawi or just the general population to identify what are the key priorities at national level and not at the donor priorities. So it could come in today and say, coming in as a donor, as Dr. Riro, and say, all I want to do is, let's say, prostate cancer. I mean, I'm not saying that prostate cancer is not one of the priorities, but actually, if you ask the government, they could potentially be having more priority areas that to work with. So most of this acknowledging that resources are limited by their competing interests. Where do we put money that we get the most out of it? And then what this presents then is how to coordinate resources behind the UHC agenda, because then you have many siloed ideas around this. And what will be important for us then as parliamentarians is how do we push laws that drive a more unified approach towards how resources are used. So, one of the countries, and I'm sure you've had this being mentioned over and over again, especially around how Rwanda has dealt with this, is all donors must, especially be it the Global Fund and others, are asked to put money in one pot where this will be managed to purchase care. And so is there a way in which we can drive resource allocation, especially from donor funds, to be channeled towards maybe certain spaces or a single pot that then redistributes, and with a well-coordinated mechanism without having different priorities of donors, then diverting attention from the core priorities at the national level. The other side, which is a challenge on prioritization, is supply side readiness. So you find that the issue is availability of quality of services becomes a challenge because these are coming as a small silos. So in terms of the supply side, then we have challenges, especially because all that is left, you train the HR or get drugs, infrastructure, and all that. And so there are usually challenges in terms of just getting the supply side ready. And then you have to then have a bigger chunk of services still being accessed through out-of-pocket expenditures. And so happy to, again, explore in terms of what are other countries doing, especially to just see how to address the challenges around fragmentation. So what has been happening and what are some of the work that you've been doing, especially to define resource allocation and spending? And I think I've highlighted this, is defining the package. So, when you look at what you've done in Malawi, it's been essentially trying to drive a support towards setting a very cost-effective set of services that can be provided, which now cuts across the different funders. So if you look at some of the work that you've done is around resource mapping, which I've mentioned before, and managed to harmonize what we call national health accounts to just help in all that conversation around aid coordination. So if you look at what is the distribution around resources in Malawi, as I mentioned earlier, where is the money coming from to services? So you find, almost, as I mentioned, almost 70% of the resources coming externally. And where is it coming from? So you find Global Fund as a bigger share, and then we have USAID, CDC, FCDO now, the Norwegians, Germany, World Bank, Gavi, UNICEF, MSF, and others, and other funding sources. And so what will be interesting for us is what this has enabled us once funding, then it becomes easy to come to Global Fund and say, okay, these are resources you're putting in Malawi, this is where it's going, how can you coordinate better, let's say with USAID or CDC or FCDO around that. So I think that sort of an approach becomes helpful, and with the support of Parliament, that could actually be enacted to drive a more cohesive sort of approach towards how donors drive resources across the country. So defining the package of costs has helped improve coordination, and which I think earlier on I mentioned that there's this leads to fragmentation. So to define the package, what we've done is we've defined the needs and targets, and which we have worked against a package of essential services. And at the same time, we've been able to track all resources in the health sector to see who's paying for what and where the gaps are. So that becomes a very helpful kind of approach in terms of how we can shape a service provision as well. So in terms of how we've managed to sort out the supply side readiness, so we have so one of the key approaches that we have been thinking about is to allocate resources to fill the gaps between the current resources and targets. But the most important point is to move towards a service delivery that reduces duplication. So that becomes one of the approaches that we've used, and happy to see how the government has been quite receptive around how some of these pieces are moving. Maybe just moving down to South Africa as one of our case studies. So South Africa has a two-tiered health system, which then we're looking at, the public sector and the private sector. But the most interesting thing is, and especially looking at, I want you to look at the blue color. The blue color is essentially a large of it government funded, and the green one is a private health insurance or private medical schemes. So the point I'm trying to drive in this is, if you look at it's in the private health insurance covers 16% of the population, but in total, it accounts for 45% of health expenditure in South Africa. So you're looking at 45% of the money spent in South Africa goes to 16% of the population. And so what the point I'm trying to drive, sometimes, yes, there's money in the system, but you find that in certain cases, a larger chunk of that money goes to the few, who in this case now I'm talking about the 45 going to the 16%. And so if you look at the remaining, then 82% of the population is catered for by the 55% of the resources. And so how do we drive a more equitable society? By making sure that there is cross subsidies around some of these elements that we can be thinking about. I'm happy to also talk about it in terms of what that could look like. And I know there's been, and this informed the current drive by the South African government to have the national health insurance that sort of becomes more encompassing to try and bridge the gap between this sort of gap that exists between the private sector and the public sector in terms of health spend. So what are the challenges to prioritization? One of the challenges is actually the multiple institutions and processes and stakeholders. And so what that has led to do is there's a misaligned objectives. So you find the private sector has other objectives, the public sector has objectives, and these are populations and present challenges in terms of how can we have a more cohesive approach to shaping a health system. Then the other bit is just the differences in terms of the essential medicines list for the different teams, clinical practice guidelines. When you see they are different in different groups and national policies, now trying to respond to each of the different segments becomes a challenge to that. And this leads to inequity and a mismatch between policy and reality. So there's aspirations in a reality around how this ought to be, but with this sort of divide between the private sector and public sector, then we have some kind of a mismatch in terms of what we want to get, especially if you're looking at a national level sort of health system improvement and improving health outcomes. So there's also the tension between UHC and what can be financed. So if you look at there's rising costs, especially in the private sector, but there's this whole interplay between cost and affordability. So as the costs accelerate or go up, then there's the interplay that we have to think about how that works. Then there's what do we take, especially around progressive realization of rights to health, because there's that sort of inequity that means other people have more access than others. And what are we going to do, especially as Parliament, to drive sort of equity across the populations? And finally, there's pressure on the prioritized package to expand in South Africa, and I guess across a number of countries. But how do we, even as we expand the package, how do we make sure that the relationship between our national aspirations towards UHC and especially the advocacy groups are also driving some sort of equity across the different population groups? So NHI, as I mentioned earlier, is one of the drivers that the government of South Africa is trying to drive towards equity and efficiency. And to do this, what they are doing is the national health insurance, they're looking at it as one of the approaches to improving equity, to addressing inequity in health spending. So I'm really keen to see how this turns out, especially when it hits the road, because sometimes policy level, the technical perspectives, it looks quite doable, but again, things might turn differently when it comes to implementation. So really keen to see how this turns out as the South African government rolls out the national health insurance. So we should also ensure that everyone has access to, as much as there are all these institutions, let's make sure that everyone has access to a defined benefit package. At the very least, all essential services are accessible to everyone without having to have this inequality that exists. So what are they going to do, especially to address the tension between the UHC and what can be financed? What we have to always keep in mind is, let's start with primary healthcare as a starting point, because if we're able to cover the very basics of essential services, then that sort of eases the tension that exists between, like, are we moving this direction? Their private insurance are able to afford this, but can we at the very least have at the bare minimum the whole population being able to access essential services through the primary healthcare programs? Then the other bit is, how do we deliver the most cost-effective services to the whole population? And so that's been one of the challenges and one of the things that NHI wants to address, but at the same time, gradually having an aspiration of expanding a package over time to the whole population. So a part of the case studies, and I know I'll share this, part of the work that we've done with the SADC Secretariat, and happy to also talk to SADC PF, is case studies across the region around how benefit package in practice has been, and especially for the 3 countries that I've mentioned in the SADC region and the other 3 countries outside the SADC region. So we have case studies that we're happy to share with you as after this, and happy to also get some of the questions from you as well. Then the other bit that we should be clear about is placing SRHR at the heart of PHC, which then we should be looking at some of the bits that we mentioned in terms of what the Lancet SRHR Commission package of SRHR services indicated. But some of the areas that we continuously omit in all this, and which becomes important to also think about, is what are the other sectors that have an impact on the health sector. So if looking at education, for example, it cannot be understated in terms of what role it has, especially in driving health outcomes, because awareness creation becomes one of those empowering opportunities for people to make decisions about care seeking. And what about human rights and civil rights? So we have to always care for everyone and make sure that constitutionally we have all this embedded within our constitution, how health is a right, and health is a human right. Let's make sure that we take care of that. And finally, let's think about historically underprovided services, especially historically underserved populations. How do we make sure that their packages actually access that? So part of this we've highlighted in this this sort of brief, and we'll be happy to share with you what to the team and the SADC PF as well. So let's quickly look through, like, across 3 countries in the continent. How does this play out in terms of services recommended and included in the benefits package? So if you look at the Nigerian basic healthcare fund, the interventions included. So we're looking at, they're not explicit on the benefit package, but we can see that they're counseling services included. And if you're looking at specifically around the SRHR services, this is what comes out quite clearly on the basic healthcare fund, basic PHC fund in Nigeria. And then when you're looking at the ANC, they have a clear outline around ANC, the basic and comprehensive emergency obstetrics and neonatal care is also highlighted. In Rwanda, although not clearly, this is something that I've been revising in terms of trying to make it very explicit, is the service package outlines promotional activities at community level, and they are clearly highlighted in terms of what people deserve to get. And when you're looking at antenatal care, postnatal care, and what we're calling emergency or comprehensive obstetrics care, that's something that is clearly highlighted. At the same time, when you look tonight to Ethiopia, it plays out quite significantly in terms of what is covered and captured in that. I mean, this is quite, I have to also apologize for having quite a busy slide, but it's just picking out some of the areas that different countries are addressing to make sure that we have essential services, and more so essential SRHR services included within the package, and the policymakers driving advocacy and allocating resources geared towards making sure that SRHR services are afforded and accessed by the population. So what is the role of Parliament in achieving UHC generally as a way of conclusion? So for us as CHAI and as technical support to the region and the continent as a whole, our work has always been apolitical, and we've always view ourselves as providing technical support to ministries of health and finance, solely to just deliver these services to the population for us to get improved health outcomes. But also just understanding that to support the path towards UHC, we need to understand the benefits who are provided to who and at what fees, both in terms of policy and real life. And then to understand what is missing and what is covered, or can't afford to access. So continuously having to talk through this and working policymakers to be clear around this. And then the other bit, especially in Parliament, is through budget oversight, ensure resources are allocated towards health. I think this cannot be overemphasized, and that's what I started with, to say, let's step back, think about what are the resources available, how can we provide oversight, and make sure that even the medium-term expenditure frameworks that are happening across different countries, we're able to ensure that resources are reaching to the areas that they needed to be, and especially health, and then particularly in areas that we get the most out of the money that we spend on the value for the care, as I mentioned, PHC and SRHR. The other bit that should be important, especially in providing this oversight, is data and monitoring systems to make these trade-offs. I think once we monitor sort of how our investments are going, becomes important for us to think about it. The other very important aspect that Parliament plays a role in the Public Finance Management Governance Act oversight. So if you look through what is happening across a number of countries, is yes, money can be provided for services, but does it reach to the service delivery points? So if money is coming from the Ministry of Finance, but it has to go to the local authority, the local government, then to the facilities, are there bottlenecks that we can enact laws that actually unlock those bottlenecks to get the money to where they're supposed to be? Because it's not enough, again, I emphasize, that we have resources, yes, allocated to health, but does not reach to the service delivery points. And the other bit that becomes, and all this is embedded towards the public finance management laws. And so one of the asks that I have, and even as we look to the plenary that is on that I think the Honorable Secretary General highlighted, is just how well are we shaping as parliamentarians the public finance management, and to acknowledge the complexities of health and to make sure that money reaches the service delivery points, especially in the public sector. And then some of the elements that we have to think about, that how do we protect the core services through legislation? So legislation that acknowledges that certain services must be protected, given how sensitive and how important they are to a segment of the population, especially those that are vulnerable. And so I'm thinking about, yes, there is resources allocated, but there are all these other small yet very impactful ways in which we can drive change by making sure that resources are equitably allocated, efficiently spent to deliver the most in terms of the healthcare spend. So I'll wish to stop there. I just wanted to run through, especially around some of the thoughts where the Parliament can play a role in terms of, yes, we have raised resources, Now let's come down to say, let's allocate them, but not only allocating, but let's make sure that they actually reach the service delivery points. But even once they reach the service delivery points, they're actually driving outputs. And the outputs that we're talking about in our patient seen are not just seen, but actually improve the outcomes. Not only that we just want to keep them alive, but we want them to lead quality lives. Why do we want them to lead quality lives? Is also now stepping back and looking at health is not just an expense. Health is health investments are investments. So we're looking at if we are able to make people healthy and be able to be productive, that has a contribution to the economy. And I know this has been quite a challenge in terms of how we, the health sector, can frame this to either the ministries of finance, to parliament, that let's not look at this as just a recurrent expenditure. This in itself is an investment that we have in people that are the primary drivers of the economy, by driving them, by keeping them out of hospitals, or keeping them out of the sick beds, they're able to produce and support the system as well. So viewing from your role that health sector as an economic question, then that can also drive in terms of how we have conversations, because it's easy sometimes to say we're building a road in an area, we're building this industry or any other or energy sector, or build some of these big industries, because we can clearly see the monetary benefits in terms of we put in this, we'll get this number of people employed, and this will pay taxes, get this much of taxes. But if we have to do, let's say, advocacy at parliamentary level, then it's that shift of health sector not just being an expense but an investment. So in my sort of conclusion for this presentation is just how we look at our role, especially in the health sector, how we become champions of driving investments in the health sector, not only just as a whole, but looking at the specific areas that need us to really focus and prioritize, especially when you're talking about PHC or primary healthcare and SRHR. So I wish to pause there. And I know this has been quite a bit of something to chew. I just wanted to leave us with a significant amount of time that we can maybe spend to ask questions and maybe have just a conversation on concluding. But most importantly, try to get what I'm calling an action plan towards the plenary later in the year. That what are these elements that we can do, and also just a question for us. I think also I'm happy to hear what more can we do to support the countries in the region, both at the secretariat level of SADC PF and the member level. As I mentioned, we have countries across almost all the countries in the SADC region. So that can also inform part of our support more at the parliamentary level, but even at the Ministry of Health level, and Ministry of Finance level, or other agencies affiliated with the ministries that I talked about. So thank you, and I wish to pause there for questions.
Thank you very much, Dr. Rio, indeed, for such a resourceful presentation. At this point in time, honorable members, I would like to open up the floor for deliberations from members, either being remarks, being comments, being questions. We will also give the opportunity for our citizens in the gallery to be able to have an input on the presentation that Dr. Rero just gave. Honorable members, the floor is yours. Can you indicate by hands if you have any questions, any remarks, any comments, any clarifications that you're seeking Dr. Rero to reiterate? Honorable members online as well, kindly raise your hands so that I can recognize you. I believe after this presentation, really, there should be some engagement based on I know that we are approaching lunchtime, but it would do justice for us to deliberate a little bit before we break out for lunch. Any questions that we may have, any points of clarifications that you'd want to have reiterated, any contributions at all? Honorable member from Eswatini.
Thank you, Chairperson. Thank you once again for the very insightful presentation. It really does.
Excuse me, I don't know whether it's the volume at the tech team. The tech team maybe could work on the volume. I don't know whether those online, they can hear, because I feel like the volume is quite low. I don't know whether I'm the only one who feels that.
I can hear on my end. Probably, maybe let's assist technical team. Ronald, kindly
Technical
assist
team, could you work on the
Dr.
volume?
Ferrero, would any better from your side?
Honorable Chair, are you hearing me?
Yes.
Hello?
I can hear you, but it's very, very faint. So I'm asking whether the
Dr.
tech
Riro,
team can find a way of raising the volume.
Maybe mute original audio. Can you hear now?
Yeah, Madam Secretary, I can hear you, but the member of Parliament for Eswatini.
Dr. Riro, are you hearing me now?
Yeah, I can hear you now.
I think they've adjusted the volume. Honorable Chair, thank you for the opportunity once again. And I just want to reflect on the presentation that we just had. And for the benefit, Dr. Riro, I was also appreciating the quality of the presentation. It really does give us a good perspective into what is expected of us as parliamentarians, and how we can really support the whole health financing conversation. Chair, as Dr. Rui was presenting, I actually, in my heart, I think we need to delve deeper into the management aspect of the financing, because it's one thing to allocate resources, but the management aspect of it is actually as good as not having. I mean, it's critical as I don't know how I can even say it, but what we need to do here is to, on the management side, continue giving focus to the digitization, because in most countries, including my country, I think the biggest challenge for us is the whole issue of inventory management and procurement. Because it's one thing for government to spend money on the medication. It's another thing if there's no close monitoring on the reorder levels and making sure that we never run out of stock. And we know exactly when we should replenish stock. I know that this is more process management, but I think from a policy point of view, we do need to find ways and means of supporting our governments to pursue the digitalization agenda. Also, in terms of the distribution of the medication, in Eswatini we have a facility which distributes medication using drones. It's a first in the country, and it works because sometimes we have emergencies, and those sort of operational efficiencies will help a lot in terms of making sure that the allocated resources are fully optimized and they reach where they are needed the most. And the whole purpose of allocating those resources is realized when access to that healthcare service is realized by our respective communities. Chair, I submit. Thank you.
Thank you very much, Honorable Linda. Is this Nkumalo from Eswatini? I would want to open up for more members to engage, unless we are convinced that we don't have any members who want to contribute. From online, I do not see any members who have raised their hands. That would then mean we don't have any further deliberations coming on from honorable members. Even from the citizen side on the gallery, I do not see any hands being raised. If that is the case, honorable members,
I can see the Madam Secretary has.
Madam SG has raised her hand. I can see that. Madam SG, may I afford you an opportunity to say your remarks, please? Thank you.
Thank you, Chair. I was afraid Honorable Dr. Ruro will conclude before I make a few asks. Yes, Chair. Thank you so much, Dr. Ruro. I think I must, honorable members, appreciate that Dr. Ruro has brought you into the discussions of ministers and governments, so that when you engage with the budget cycle or when you engage with some of the resolutions, which often are taken in your absence, there's context in terms of how you can indeed work together with governments to facilitate the implementation of such. Let me start with the first one that we spoke about earlier, which Angola, mentioned about the 15% or allocation of national budgets to health as per the Abuja, estimate. And I'm using the word estimate deliberately, honorable members, because I once read an article where somebody said 15% of an elephant is not 15% of a chicken. So precisely what Malawi indicated. Sometimes this can be misleading, as though it's basically saying we've done it. It's 15% we've dusted. And yet we are also failing to even reach this 15%. So what I would like to say, honorable members, is that I think Dr. Ruro has given us advocacy areas. I think he has really charted the way for areas which, even in our report, will not per se be repeating his recommendation, but we will recognize and also begin to say this is an advocacy agenda for this committee going forward. I think he has made it very clear. Why should it be an advocacy issue? Because we need to allocate for resourcing. We need to make sure that we have clear arguments to invest in. He's shared a lot of cases, examples across the countries. So maybe when we speak to some of these issues, the scenarios that he gave, I would love in a session like this for honorable members to bring the lived experiences of their citizens in their communities. And maybe in future, at this point, may I ask, Honorable Chair, which member, Mr. Manzi, you are talking to the chair and I'm trying to intervene. We could find out which country is willing to host this committee in their country, where next time we don't meet in Johannesburg, but we meet in a country where maybe Dr. Ruro will tell us which country can give us the experience of some of the issues, or which country is accessible enough or willing to share the strengths and weaknesses of some of these scenarios that are there. And I'm saying this, Honorable Chair, because we cannot all be talking about universal health coverage without realizing the onerous task that is placed before us as part of the political commitment. Are we indeed just saying we have Abuja Declaration for Health, we have universal healthcare access? Do we realize that we are saying all people, and I underline, must have access to quality healthcare? Notwithstanding the issues that we've raised around the macro environment that Dr. Ruro spoke to, notwithstanding the issues around innovative funding, notwithstanding the whole issues around the allocation, the financial gaps that are there, that really should preoccupy us. The issue of the basic package of services. Maybe if honorable members can really delve into that and say in this committee, what is it that we can say can be included, excluded? What does it mean for the people that we represent? I think this committee would have done very well to break down this appreciation of what has been said. Because ultimately, I believe our report will underline the fact that we want to end inequalities. Because the comparison that is being made, whether it's this country, that country, and the gaps that are being highlighted, are really saying, but how do we get on track? How do we get on track for our communities? How do we get on track with our governments? How do we make sure that we know about every resources that is being allocated, whether through the donor pool, whether it is private sector, whether it is actually through government? And he raised an issue which I was very excited when you raised it, because we have a model law on public financial management, which raises one of the issues, it's a nerve, the issue around debt, where we are enjoining countries to really reflect on the obligation to service debt and also the obligations to provide some of these basic services to their citizens. And I know we had looked at what the SADC had said, let's not go beyond 50%, but it's a very contentious issue. But I think it's a matter for advocacy and reflection, which I'd like to throw into the basket of the advocacy agenda. Because like you said, Dr. Riro, definitely it will affect education, definitely it will affect health, definitely it will affect social service. It's not just an issue where it's allocation, even if you reach this level without a multi-sectoral lens to how this plays out. And I think I can't say it any better. The global reforms. Hello?
We've lost the room, SG.
Oh, speaking to ourselves?
Yeah.
We can still hear you, but you will hear us back.
Hello?
Just because we can hear us now.
Hello?
Yes, Madam Z, can you hear us?
Yes, I can. Did Mr. Manzi switch off the lens now so I can't see him? What happened?
Yeah, no, our cut interrupted our
Oh, you're in the
connection.
dark actually, Mr. Manzi.
Yes. But we
Anyway,
have heard now that
let me
you
stop
from
there.
now.
Let me stop there because maybe also technology is telling me that I'm speaking too much. But let me stop there to say it's an advocacy agenda, honorable members. How do we build on this robust information that we've been given? And let me end by saying there's no other lens to use except the lens of the political economy analysis in looking at these issues. Because you can't be concerned about the people that you represent. Only look at health and not look at the economy. I think here it's a relationship between politics and the people that we must really take into account. And it doesn't matter what we say or do, how do we increase some of the efforts that are already in place in our countries, whether it is through tax collection, some mentioned tobacco earlier. I know Zimbabwe has the AIDS levy. You know, are we really taking this money where it's supposed to be? Because that's another question. You know, when we collect, does it actually go to these, you know, to ensuring that we cushion ourselves in the long run? And one thing that I'd also like to point out too is that we have the Africa scorecard on domestic financing for health. Let's also just have an appreciation beyond what we think we know, just to look at the picture. It's a dashboard in terms of what is really happening in this area. And we must make sure that we look at that in relation to the epidemiological information that informs us about the burden of disease, our populations, among others. Otherwise, we'll forever think 15% of Abuja is adequate, or that it is too high. We should not even be getting there. In fact, we have to exceed it because out-of-pocket expenditure cannot continue. Otherwise, there will be a huge uproar from citizens, and this will affect the democracy that we want to live in, all of us. I thank you, Honorable Chair, and thank you so much for your contribution, Dr. Riro, and honorable members. I really enjoyed it, and I sincerely look forward to what this committee is going to really develop as a pathway to sustaining this particular indicator. I'm also inviting members to contact SRHR researchers based in their parliament. Some of you have budget offices like Malawi, Zimbabwe, Zambia, South Africa. Please get in touch with your budget offices so that you really take this issue forward. And like Dr. Riro says, for us, it can be an area of interparliamentary cooperation where they take forward and assist countries who already have budget offices. So we don't start from the beginning, but assist members with the analysis and then contribute to this understanding of funding allocation, innovation, and the financing gap, among others. So thank you so much, Honorable Chair, for indulging me. And I'm happy that we have not been disappointed and the members have, engaged robustly with what is coming out of this meeting. Thank you.
Thank you very much, Madam SG, for those remarks. I think they are simply reminding us why we were here. That you believe that there are not expectations in our
We can't
engagements.
hear you, Chair. We can't hear you. You are muffled. I think it's technology.
Wow.
GSG, can you hear us
Samanzi, I
now?
can hear you clearly now. Yes.
Okay. I think
Alright.
we were on a power outage for some time.
Yes,
And
yes.
the
Apologies.
members in the room, I think, lost a big chunk of your intervention. But are you able to hear us now?
I can hear you.
Okay.
I can hear you.
Okay, fine.
Well, if
Okay,
it's a
fine.
big chunk, I wouldn't know where to stop and
Yeah.
where
No,
to start and where you lost me. But I think Mr. Vinvai, it's on YouTube as well. I think you can listen to it. But I was really, really underscoring some of the issues that were raised. I think Dr. Riro can also reiterate when he closes and make the linkages, because I was trying to develop a work plan, so to speak, for the committee to really focus on what they're recommending to plenary in terms of practical issues to locate the committee so that we're able to follow up in that regard. So please kindly assist me so that you don't have a power outage from and then miss out on the important intervention from Dr. Riro. Thank you.
Thank you very much, Madam SG. We'll definitely have to follow up with other platforms, the recording platforms that had your intervention, and members can be able to go view it from there. Before I call upon Dr. Riro to close, I have an honorable member from Namibia who yes, Honorable Kafula, who would want to have an intervention. I would just kindly ask that it be quite short. We are already running out of time. We'll be heading out for lunch, maybe in the next 10 minutes. And then before we head out for lunch, we'll have Dr. Riro to close for us. Thank you.
Thank you, Honorable Chair. My intervention is short indeed. Initially, I would just like to find out if Dr. Lilo can help us in regard to the SADC PF recently developed, the SADC model law on public financial management. I would like to perhaps, if he can help us as to how can we ensure that the law is widely understood and domesticated, and when it comes to also implementation. In short, just that I want him to assist us in this regard.
I hope, Dr. Riro, you were able to get that. Madam SG as well, with your oversight, you were able to get that important question. At this point in time, I'm going to call upon Dr. Riro just to give the closing remarks as we are heading for lunch. Madam SG, I'm not sure if for the session after lunch he will still be with us, because after lunch we have a discussion, a brainstorming discussion where the committee is going to be putting together the resolutions on health financing, as well as drafting recommendations that will then be presented in the 56th plenary assembly. So before we break for lunch, I would really want Madam SG to give a bit of guidance in terms of how the session after lunch is envisioned, and if we will still have Dr. Riro with us, or these closing remarks will be the last of our interaction with him. Thank you. Madam SG?
I'm on duty, Chair, and I'll be here. Dr. Riro, I know he had indicated a time frame. Maybe you could indicate.
Over to you, Dr. Riro, and then you will be able to tell if you are available also for the session after lunch.
Okay, good. So, and thanks again. I think the volume went pretty low, so I was not quite clear before, but right now I think I heard you quite clearly. I hope you all can hear me. And yeah, so thanks again. I think there's been good interventions. I'll probably build from the honorable member of parliament from Eswatini, who, I think summed up some of the bits that I mentioned, that if you look at elements like, so how do we drive, even as we talk about the bigger buckets of raising resources, how do we even put in laws around innovation? If you're looking at, let's say, aspects around procurement or pooled procurement or even inventory management and a couple of others, to just ensure that, yes, there is money, but there is actually service delivered. And I think she went ahead to highlight the issues around using drones to deliver products, essential products, especially in emergency, which I think, even as we think about financing, there's more role that the parliament can play to shape that ecosystem, to make sure that, yes, there are other pieces that we can do to make sure that that gets there. And again, thanks to the SG. I think SG, you probably highlighted a number of elements that I'll wish to even emphasize, but also appreciate that. For me, I see this as a partnership that, but it should not end today. Maybe to be strengthened, not only for this forum, but even a continuous engagement that can go to the country level. We are talking about going to the countries that we work in, be it Eswatini, Lesotho, or Mozambique. It would be nice if we can, we can start building that kind of a plan to say A, B, C are the priorities that we can work with. Then we work together to actualize that, especially around mobilizing resources. To the Namibia question, just before I give closing remarks around the PFM, around the model law on PFM, is something that we are very happy to support in terms of either breaking it down to parliament, breaking down to the people that are concerned, to also, even if there are areas that needs to be tweaked per country, because it's sometimes harder to pick a law and actually tweaks across the region, because the governance structures are pretty different, right? So if we can also, that's something that we're happy to do in terms of taking that model law, then domesticating it across the different countries, is part of work that Chai can do, and happy to work with the SADC PF to actualize that. So that one is something that I potentially could be a work stream that we could work with, and happy to work with the SADC PF Secretariat to see how we can work on that. To my closing remarks, there was a time I was talking to the teams from the Ministry of Finance in Sierra Leone, and the official at the Ministry of Finance told me something quite interesting, and told me, so I was asking, how come continuously there is low resources to health sector? And this is what he had to say. He told me, the Ministry of Health, you have too many sponsors. Even if they came and asked for $20 million, if we give them 10, they don't come for the other 10, because they have other sponsors, they have other donors to give the money to fill that. So what we're continuously seeing is we might not continue having those sponsors in the long term, but how do we, even with those sponsors, not to think about them as sponsors, but as people that are complementing the health system to get more resources into the health sector. And so I think as Parliament, let's step up and think about donor funding or development assistance as a complementary fund, not just coming to replace the funding that, or replace or take up our responsibilities in terms of what responsibility we have to our citizens, to the people that we present in Parliament. And so that becomes an interesting piece that we should think about. And finally, what could be possibly a clear action plan for me and the team that we work at Chai is a more cohesive sort of a working relationship with the SADC PF and the members of Parliament themselves, and the Committee on Social and Economic Development, to sort of come up with a way in which we can develop clear materials for policy advocacy, either to support in terms of some of our research that we do to break it down for you to help in the terms of budgetary advocacy towards health and more so towards SRHR. And that's something that I think will be very helpful, and happy to see how we can partner in this to drive that sort of evidence-based advocacy that we can drive in terms of improving resource allocation to the health sector. And that's something that, continuously we can identify areas of support. And at this point that I'd like to register my gratitude to you for having invited me, and my colleague Cynthia, who's of a repertoire in this, taking notes and taking all the speech that we've talked about, which we'll be sharing with the Secretariat as we work on the report for this. And it's something that continuously, we don't have to wait for another year to meet. We don't have to wait for longer. It's a continuous process that I'm trusting that we can continue to have. So thanks again, and really appreciate having us, and looking forward to working together continuously, because we have a responsibility to our citizens. We have a responsibility to our the people that we represent in Parliament. And for me, as an African, and as a person who has benefited from people that have put in laws to enable me have access to care, have access to education, have a responsibility to provide technical support to drive some of these changes across the continent. Thanks again.
A very warm gratitude to you, Dr. Riro. Just one piece of question that we really want to get clear from you. Will you be available for the after lunch session, or we have been able to go through the time that you had allocated? Dr. Riro, did you get that? Just wanted to check.
No, I didn't get it. Could you please repeat it?
Yes, we just want to check with you if you will be available for the after lunch session, because we are going to break out for lunch now. We just wanted to.
I will not be available for the after lunch, but we're happy to connect afterwards. I'll share all the materials with the team. And I think for me, this is the point that I'll drop off. Yes.
Okay. In that case, I would like to also express my gratitude to you for taking time to speak with us for this long. I know we may have taken some extra minutes of your time, but I'm pretty sure even for yourself, it was worth it. The kind of engagement that honorable members were able to give, the kind of questions and their depth that they were asking was not in vain. We promise that from here in our afternoon session, we're going to use a lot of information that you have shared with us to shape the reports that we'll put together. And as you are communicating with the SADC PF Secretariat, they will know how much of our work they will be able to share with you. And we are hoping to get more input and support from your side. The resources that you presented today, we are looking to have the content, and through SADC Secretariat, we will know how much of that we can be able to access. With that, we would like to thank you so much for taking time to speak with us, together with other members on the plenary who contributed to this meeting. With all that said, I would kindly ask honorable members that we break for lunch. Looking at my time now, it's 12:45. Would we kindly reconvene back here again at 1:45? Thank you very much. Thank you very much, Dr. Riro. It was a great pleasure to have you and the rest of the team that won't be joining us after lunch. Thank you.
Thank you.
Log out, SG.
Mr. Manzi, I'm waiting for my lunch.
Gee, you are invited. Please join us in the restaurant for lunch.
I'm going to get you.
Most welcome, SG.
It went well, thank you.
that we use. Ngiyasuggest nje.
Honorable members, our time has arrived and we are a bit behind time. I would like to call the meeting back to order. Honorable members, I would like to welcome you back from our lunch break. I hope you all had great meals. At this point in time, we are getting into our last session of the day, where we are going to get into a brainstorming session, where we would like to put together some of the resolutions for the Committee on Health Financing and put together some recommendations that will form part of our report that will be presented to the 56th Plenary Assembly in December in Zambia. I would like to, sorry. Madam SG, we are back online. Just want to check with you, honorable members online, if you are back from your lunch break. Madam SG and honorable members, would you kindly confirm that you are back in connection with us so that we resume our meeting? No one. Hello, honorable members who are joining us online. Would you kindly confirm that you are back in connection with us so that we kickstart our meeting? Honorable member from Seychelles, I can see you online. Would you kindly confirm if you can hear us? Maybe even other members thought so.
Yeah, so Honorable Chair, the SG whom you are inviting to take the floor, she's yet to join. She was offline, so she will join anytime. But I think the gist of the matter is that honorable members, you have heard from the submissions, the presentation and submissions from the citizens. So there could be some key issues that you feel that they should not be omitted from the report that you are submitting to plenary in December. So those are the things that members can speak on that. We'll take record of it, then as usual, Secretariat will put together a report that is submittable to plenary. So I think that's the exercise that we are doing. So any issue that you feel that perhaps it can be flagged out and should be included in the report, those are the things that members should be speaking on. Thank you, Chair.
Thank you very much, Mr. Manzi. Honorable members, there it is. This session basically is of us identifying certain issues that we truly want to have reflected in the report, with certain recommendations and resolutions perhaps that we would want should be presented at the plenary assembly. So I open the floor for honorable members and including the citizens who are on the gallery, either joining us online or in person here with us. I think this is a critical point where really some of the things that we learned through the presentation that we would want to see getting implemented, we can be able to raise them in this session and just make sure that they will be part of the report. Just to do a bit of reminder in terms of what the presentations that we saw talked about, the theme definitely is issues around health financing. We did hear from Dr. Riro on issues around resource mobilization, where he shared with us how different countries have their health care financed from different sources of funding. He did even make us realize what portion of funding seems to be more across different countries, which portion of funding he recommends should be increased versus other forms of funding that are available. So these are things that we may be making resolutions around to say on health, on resource mobilization, what is the resolution of this committee and recommendations that he would want to make to the plenary around resources mobilization. Then we can move again to resource allocation, where he did also share a couple of things around resource allocation. What are some of the factors to consider when doing resource allocation? The last thing he talked about resource utilization or the use of resources in order to achieve efficiency. So these are areas that we could possibly look into and try to make recommendations on how to achieve the best level of each of the three different stages of resource mobilization, allocation, and utilization. So I would really love to hear any submissions, honorable members, before I bring forth what I have in mind. Otherwise, I will then intervene as members are still processing the information and seeing how they can be able to contribute. I'll just give 2 minutes to see if we are going to have any members who want to contribute both physically and online. Thank you. We have honorable member from DRC, that is Honorable Kenda, who would like to provide a submission. Thank you, honorable member. The floor is yours.
Merci beaucoup, Monsieur le Président, pour la parole accordée. J'interviens, comme vous l'avez dit tantôt, pour partager la petite expérience de la RDC à ce qui concerne la mobilisation des recettes. Et puis après, je pourrai encore intervenir plus tard, après que j'aurai écouté les interventions des autres membres, parce que c'est un échange interactif. Alors, au niveau de mobilisation des recettes ou de ressources pour intervenir efficacement dans le secteur de la santé, c'est que ce qui concerne plus précisément en République démocratique du Congo, la couverture santé universelle, il y a un service qui a été créé, c'est sous forme d'un service public ou établissement public. C'est un établissement public qui ne s'occupe que de la couverture santé universelle. Et en tant que tel, en tant qu'établissement public, cette structure-là a la possibilité elle-même de pouvoir mobiliser des recettes. Donc, en sus de ce que fait le gouvernement dans le budget de l'État, et comme c'est un établissement public, il peut, jouissant de l'autonomie administrative et financière, mobiliser des recettes pour pouvoir atteindre les missions qui lui sont assignées dans son acte constitutif, dans ses statuts. Donc ça, c'est une expérience de la RDC. Donc, la couverture santé universelle a été érigée en un établissement public dirigé par, il y a un directeur général, il y a en même temps un conseil d'administration et avec les administrateurs. Donc, cette structure-là, elle peut mobiliser de ressources pour pouvoir mener à bien l'objectif poursuivi, c'est-à-dire celui d'accorder les soins de santé à tout le monde, les soins de santé de qualité. Donc, en sus de ces ressources qu'elle peut mobiliser, le gouvernement aussi peut trouver des moyens qui sont précisés dans le budget de l'État pour pouvoir atteindre le même objectif. Voilà ce que je peux dire pour l'instant à ce qui concerne la mobilisation de recettes ou de ressources plutôt dans les secteurs de la santé. Merci.
Thank you, Honorable Member, Honorable Kenda from DRC for your submission. I would like to see if we do have any submission from other honorable members, either being online or physical here with us. Otherwise, I'm going to put forth my proposal that I would request this committee to consider as part of the resolutions that can be owned up by the committee as recommendations that will be included in the report for presentation in the 56th plenary assembly. Following the presentation from our resource person, as I mentioned, the presentation covered a range of stages for health financing. First of all, we had a presentation tackling issue around resource mobilization. We had parts of the presentation that specifically were talking about resource allocation, trying to ensure accessibility and coverage with the resources that have been allocated, that are available. And then we did talk about resource utilization, how to improve efficiency of the resources that we have, how do we manage the resources that we have. So I have about 3 recommendations that I would really like to propose before the committee to review and discuss, which definitely may end up becoming part of the recommendations that we sent into our report. The first one is, do we find it at all necessary maybe to recommend that countries consider increasing domestic resource mobilization to a certain target? We did see through the presentations that almost all the countries that were presented there, their domestic resources towards health financing were well below expectation. There was no country that was presented that we could say sufficiently with its domestic resources, they can be able to run the health systems adequately? Can we, like, just like the Abuja target for total budget for health sector in countries at 15%, can we also recommend a specific percentage of domestic resources that are targeted at the health system, such that countries can invest a lot of time in trying to build resilient health systems that do not depend on donor funding? And the target could be set as ambitious as possible, or maybe a conservative target that maybe says at least countries should dedicate or should contribute about maybe 40% of health funding to become domestic resource mobilization. This is one thing that I'm putting out there to say, can we talk about it? Would setting a target improve and even have governments committing more resources towards the health system and trying to get away from the reliance of donor funding that we see every year that it's depleting? We know donor funding, it's very much dependent on global health situations that go on. During COVID-19, we saw a lot of funding being moved away from primary health care, moving on to COVID-19. Are these things that we are going to wait to experience in the next pandemic, possibly? But if we decide to say we want to sustain domestic funding at a certain percentage, it may not be enough, but at the same time, it puts us in a position where at least we have a bit of control in terms of how our funding, our health system is being funded. That is one. The second recommendation that I'm putting also on the table for discussion is on introduction of prepaid mechanism for health financing in order to reduce out-of-pocket spending. Would you want to say anything in our report about this? We have seen how much out-of-pocket spending across different countries remains very huge. As we were discussing about the SDGs, we really want to get to a point where access to health does not impose any form of financial burden to our citizens. But if at this point in time we still have more and more citizens who are paying for their health out of pocket, what are our recommendations to actually help governments to address this issue? Can we also have a recommendation out there that encourages governments to look into other forms of health financing that could help to reduce the out-of-pocket financing? So that is why I'm putting out there to say maybe we have as a recommendation that governments should consider introducing prepaid mechanisms for financing healthcare in order to reduce out-of-pocket spending from our citizens. The last one, really, which is a bit broad, and it may overlap across all the areas of health financing, including resource mobilization, resource allocation, and utilization. I just wanted to put it as broad as possible to say, could we have a recommendation perhaps that says governments should consider introducing legislative instruments to support resource mobilization, resource allocation, and utilization of health resources to improve efficiency and quality of healthcare. So this one, the way it is, it's broad, it's leaving out different approaches and strategies. But we just want to have instruments, legislative instruments that support resource allocation. For example, we would say, can governments prioritize having tax policies that are targeted at improving resources that will be directed to health? The ones we talked about, the ones that the resource person talked about, I remember the resource person talked about a certain percentage of VAT in some countries, which then is allocated to health. He talked about 10% of airtime in some other countries that has been allocated to health. So these are all things that could come through a legislative instrument. So I'm also putting it out there to say, could this encourage governments to make more efforts to say, how do we generate more money that will then be used in the health expenditure? You know, the one that I talked about of tobacco and alcohol taxation, these are things that can be operationalized through a legislative instrument. So these are things that I wanted to put on the table for consideration, honorable members, to have a discussions about them, to say, are these things that could possibly become concrete recommendations for our report? Do we foresee any challenges in countries trying to take up this kind of recommendations? The floor is open, honorable members, for discussion. I see honorable member from Namibia, honorable member, honorable Kafula. I leave the floor open for your intervention. Thank you.
Thank you, Honorable Chair. I would like to also suggest, depending on, according to Dr. Riro indicated that they would be willing to build the capacity of MPs to do budget tracking and to make the model law on PFM understandable by MPs so that they will support effort around domestication and implementation. I therefore feel that perhaps we should also now put a recommendation to urge the SADC PF to enter into an MOU with CHAI, if that is acceptable. I so move, Honorable Chair.
Thank you very much, Honorable Kafula, for your submission. There we have honorable members. Honorable Kafula is suggesting that we have in our report a recommendation on capacity building for members of parliament around issues of public financial management, which also could even include health financing, understanding the entire process so that their interventions during process oversight will be well informed by the capacity that they would have gotten from partners like CHAI. Do we have any other recommendations or maybe discussions on recommendations that have been put on the table, whether they are being seconded, they are being supported? What are some of the challenges of specific suggestions that perhaps members would want to flag? A few things that proposers of such recommendations may not have been aware of. I also, honorable members, I really encourage that we engage in this, especially when there are recommendations that have already been put. Some reactions to those specific ones that are there on the table would help, either being supported or either more clarifications being needed on those particular ones, so that at the end of the day, they are not deliberations of individual members, then they become the collective decision of the entire committee. I see honorable member from honorable Kenda from DRC has their hand up. The floor is yours, honorable member.
Merci beaucoup, Monsieur le Président, une fois de plus pour la parole. Je salue la pertinence des propositions que vous aviez faites, là, les 3 propositions en termes de discussion. Et je profite aussi de l'occasion pour féliciter aussi ma collègue qui est à ma gauche, qui a fait une belle proposition que j'approuve, quoi. Alors, pour revenir aux 3 propositions que vous aviez faites, j'aimerais dans un premier temps m'appesantir sur la première proposition en rapport avec ce que vous avez fait là. Donc, comme vous avez proposé, voir si on ne peut pas aller au-delà du seuil de 15% des allocations budgétaires telles que prévues je crois, dans la recommandation d'Abuja. Donc, c'est 15%. Alors, moi, je crois que c'est mieux que nous puissions avoir une proposition dans ce sens-là et qu'au niveau du forum parlementaire, que nous puissions insister sur un seuil en termes de d'allocation budgétaire. Alors, mais est-ce qu'il faut avoir un autre seuil? Je ne pense pas. Moi, je propose que nous puissions rester dans ce qui existe et que nous puissions éviter de multiplier des seuils. Ça, c'est ce que je voulais dire dans un premier temps. Éviter de multiplier des seuils, surtout que les seuils-là de 15%, ça a été arrêté. Je crois que c'est consigné dans un document ou je ne sais pas moi, je crois que c'est une convention quoi, qui a été ratifiée par plusieurs pays. Alors, c'est une obligation pour les pays de pouvoir respecter ça. Alors, si à ces seuils-là, on ajoute un autre seuil, à ce moment-là, les deux pays auront deux seuils à respecter dans un même secteur. C'est un peu compliqué. Alors, de la deuxième considération est que presque tous les pays africains qui sont représentés ici, ils ont du mal à atteindre ces seuils-là de 15%. Je prends l'exemple de mon pays. Il y a quelques années, on était à les allocations budgétaires dans les secteurs de la santé, c'était à 9 ou 11%. On tourne autour de ça et qu'on est en train de fournir des efforts pour pouvoir atteindre les 15%. Alors moi, ce que je voudrais proposer par rapport à ce que vous avez dit est qu'il y ait une recommandation allant dans le sens de confirmer déjà le seuil là de 15% qui a été approuvé par les États membres et insister à avoir une recommandation dans le sens de pousser les États à pouvoir atteindre ces 15%-là. Donc, une sorte de confirmation de ce qui existe déjà et amener les États, dans un premier temps, à pouvoir d'abord réaliser la recommandation là de 15% des allocations budgétaires. Et une fois qu'on aura atteint les résultats des 15, à ce moment-là, on pourra voir s'il ne faudra pas par après proposer un autre seuil au-delà de 15%. Mais je crois qu'on peut rester d'abord dans les 15% et inviter les États à pouvoir respecter cette recommandation-là. Donc, une sorte pour nous de pouvoir insister dans la recommandation que nous allons faire pour que d'abord les États membres de la SADC puissent respecter le 15%-là. Et ceux qui sont déjà dans les 15%, je sais qu'ils ne sont pas nombreux, on les encourage. On les félicite qu'ils restent dans ça, qu'ils ne puissent pas baisser. Et ceux qui sont encore en deçà de 15%, on les invite à atteindre le 15%. Une fois qu'on aura atteint le 15%, à ce moment-là, on pourra passer à un seuil supérieur, soit de 20 ou de 25. Merci beaucoup.
Thank you very much, honorable member. I do appreciate your comments and analysis on the proposition that I put. I, however, realize that there might be a bit of misunderstanding in terms of what I had proposed and what your response is particularly on. I'm just going to make it a bit clearer so that at least if you maintain your comment, it should be exactly on what I was proposing, and also other members to be able to react to what has been clarified. My proposition was that just like we have a threshold that has been set through the Abuja Declaration, that health sector should be allocated 15% of the national budget. We should consider doing the same thing when we now look at the source of funding for the health sector in country. We did see the presentation by the resource person showing that in a particular country, we have funding that comes from donors. We have funding that comes from the pockets of individual citizens. We have funding that comes from prepaid insurance mechanisms for funding health. And then we have funding that is from the national government. And then the distribution of that particular funding has shown that government allocation is still quite low. We still have more of the health financed by individual citizens out of their own pocket. We still have a lot of health systems that are dependent on donor funding in different countries, and that does not sustain our health system. His recommendation was, let us find a way to make sure that domestic funding has a bigger portion of the funding of the health system. It does not in any way contradict the 15% Abusha declaration. It just says, even if we reach the 15%, how about if this 15%, 100% of it was donor funded? Would we say that country has a sustainable and resilient health system? Even though we have reached the 15%. But it matters more to say, where does this 15% come from? Does it come from in-country resource mobilization, or is it dependent on sources that are not sustainable and tomorrow may not be available? So the target that I'm speaking of now is saying, out of the funding that we have, how much should the country say, as the central government, we are committed to fund the health budget at this much. The donor funding will be this percentage. Maybe out of pocket from citizens would be this percentage. Prepaid mechanisms would be this percentage. So the targets we are setting are not in any way conflicting, but they are targets at different levels. In-country targets and regional or continental targets, which is the Abusha Declaration. So I just wanted to make that clear, but that does not necessarily say you change your way of looking at it, but I wanted to make sure that we're on the same page. Thank you very much, honorable members. I do realize that we have, I'll come back to you, honorable member from DRC. I do realize that we have Madam SG with the hand raised. Madam SG, would like to give you an opportunity to take the floor.
Good afternoon, Chair. I hope I'm audible.
You are audible, Madam SG, on our side.
Okay, thank you so much, Chair. I must register my appreciation for the contributions that are being made, because they can be grouped around the roles of Parliament, the mandatory roles of Parliament. And your concerns, as all the members are articulating, will touch on all the three issues for domestication, representation, if you like, and the others that are constitutionally mandated. I also particularly appreciate the fact that we are breaking down these recommendations to actions that will contribute to the broader goal, as the chair was articulating, that yes, we have this framework. Operationally, how do we press ourselves to be able to meet those targets incrementally, in view of the fact that countries are at different levels and countries may not be able to endeavor to have the basic that we require. But of importance, which the chair mentioned, how do you reduce the burden among the citizens? I think if any citizen saw such a recommendation, it will really show that your representative role is important. Others can be packaged under oversight with the bigger, broader objectives of what our governments have already acceded to. But I think let's continue in that cycle. I also liked the frameworks. And also just to caution that let's not have many recommendations that we will not be able to hold accountable on in the next session that we are going to have. But just to register my appreciation that let's continue to discuss, Honorable Chair. We will package some of your ideas as honorable members. However, I like the practicality at which this matter is being approached, because it will be a recommendation that every country at the plenary assembly would wish to say, in my country, we have moved from here to here. In my country, these are the activities that we are doing. And I'm saying this because in the SRHR project that we're implementing, Zambia, Malawi, Lesotho endeavor to make sure that there's something that they can report in terms of the shift that they have made. How do we know with the health insurance? It was innovated in this manner, and we're able to pick the debates in Parliament, the motions that were tabled, and actually the contributions by members that led to that shift. So that is why I'm happy that we're not being too global conceptually, but we are saying practically, what am I able to contribute as a member to a matter that I can claim and say, this is how I was able to influence and relieve citizens of XYZ. So thank you, Chair. Just to say that we are together, and Mr. Manzi and colleagues in there appreciate that we'll package accordingly. But for now, let us just brainstorm and contribute. We will harness and package for you in a manner that does not contradict what the heads of state and ministers have already agreed to. However, showing the complementarity of your effort, and maybe also add round tables at country level where a committee relevant, you will go and influence the relevant committees in your countries, where there'll be a round table to discuss these issues and maybe acclimatize yourselves in terms of what is really happening in your country and where are the loopholes. Then during plenary assembly, some of these things can be contributed in your country reports when the honorable speakers table these. Thank you, Chair.
Thank you very much, Madam SG. We are going to open the floor for other members to contribute. I realize that we have honorable member from Eswatini, Honorable Linda. We also have Honorable Kenda again from DRC, who would also like to give their remarks. We have Honorable Honorable Karenyi from Zimbabwe.
Thank you, Honorable Chair. And I just want to, first of all, support the contributions that have been made by the honorable esteemed colleagues in this meeting. I also want to appreciate your inputs as well, Chairperson. I do believe that all the member countries need to uphold and abide by the Abuja Declaration. When you look at the declaration itself, it was done in 2001, and that is quite a long time. So I do believe that if, as a committee, we assist and support our principals and our respective countries to move in the right direction, it will help us a lot. In doing so, Chairperson, just maybe riding on the wave that the Honorable Madam Secretary General has just highlighted, I think we need to make it practical and easy to track whatever recommendation we make. I will just put it as I thought it, Chair, and then I will stand to be guided by the esteemed colleagues in this honorable house. Chair, my suggestion is that we need to maybe consider that member countries need to set up or institutionalize or strengthen the health information systems for a more focused and intentional approach in managing health financing going forward. I do believe that if we don't have a system of tracking the direction in which we are going, we might find ourselves not able to actually, move together as a region. So I do believe that if we could maybe recommend in our advocacy at the upcoming plenary that maybe member countries need to consider setting up in place a team that will look at the accounts. I noted also, Chair, on the statistics that were presented by our consultant, that if we could have something of that sort that every country reports on a regular basis, I think it will help us a lot, because now if we do so, then we will be able to move together in the right directions. All the countries in the regions, we all have a lot of work to do, a lot of ground, to cover. But the whole SADC Parliamentary Forum and this whole gathering will help us to hold each other's hands and move forward in the right direction in an organized way. I also want to contribute, Chair, that we must also, in doing so, it will help us to strengthen the reporting systems, to improve planning and programming. Yes, so member countries really do need to consider establishing a health financing unit to routinize expenditure tracking and explore resource allocation more effectively and efficiently. I so submit, Chairperson. Thank you.
Thank you very much, Honorable Member, Honorable Zumalo from Eswatini. I did also see Honorable Member from Zambia, Honorable Karenyi. You had your hand up, after which then I will move on to Honorable Kenda from DRC.
Thank you very much, Mr. Chair. And I also want to support some of the recommendations. And I strongly feel that I think after this meeting, we are going to have some resolutions which I feel that our member countries will also go and embrace, because we also want something which is feasible. And I was taking from what my colleague have just said, the issue which I think must be done well is the issue of how do we strengthen the issue of good governance and leadership to improve the oversight so that we can have accountability in the health system. Because my worry is, do we, because in other countries, the resources are there. Maybe it's the issue of how to strengthen those kind of resources. I was just reading on internet this morning. It was like in Zimbabwe, we have got these levies like what you were alluding to, the issue of the sugar tax, the issue of the airtime, which you were also highlighting on. And one of the member of parliament was actually giving it a thought to say, we have recently introduced it, and currently, let me read as it is. He tweeted to say, sugar content of beverages has so far raised 18 million. And the issue is, it has been just introduced recently. So he was now saying the initiative is very, very good. And as a country now, we are now supposed to make a follow-up to say, how are we going to utilize it? Because the issue was, it was going to go straight in procuring the cancer machines and something to do with those kind of diseases like cancer. So it's the issue with, I think we must have a resolution on, even if we have got all these good laws and all the taxes, to say we have to go and introduce or increase our domestic funds. After that, if it means we have now a levy for sugar, where are we going to channel those resources to? Is it just going to say we have this levy without also prioritizing on the issue of health delivery? And coming to you, Mr. Chairman, the way you have said, let's try to increase our domestic incomes, like what we also have the 15% declaration from Abuja declaration. I would also want to support my colleague when he said the issue is we have got the 15% already, but most of the countries have not met. I don't know whether we have got one country here who have already met. Most of them is 10, 12, 15, 10, 12, 13, but nobody has reached to the 15%. So my worry now is if we now also introduce to our domestic, how are we going to make sure that after introducing it, that fund will go straight where it is supposed to go? So maybe we have to find a way of, yes, if we introduce it for a certain priority, it has to go straight where it is supposed to go. Like, for example, in Zimbabwe, where we have introduced the sugar levy, and it is going straight to the issue of procuring the cancer machine. So the issue is now, after you have said said it is going towards the issue of maternal health. Is it going there? How are you now going to close all those gaps and also make sure that you prioritize the issue of maternity health? So my resolution would go to the issue maybe to enhance and improve the accountability of those monies which we have already proposed. I thank you, Mr. Chair, so I submit.
Thank you very much, Honorable Karenyi, for your submission. Highly appreciated. The next honorable member that had their hand up is Honorable Kenda from DRC. Honorable member, the floor is yours.
Merci beaucoup une fois de plus, Monsieur le Président, pour la parole. Je partage le point de vue de tous les collègues qui m'ont précédé. Il y a eu aussi l'intervention très enrichissante de Madame la SG. Et j'ai bien compris les précisions que vous avez apportées à ce qui concerne la proposition que vous aviez faite. Comme l'ont dit les prédécesseurs, je crois que l'approche ici, ça doit être une approche globale. La première proposition que vous aviez faite, elle concerne plus d'après ma compréhension, l'allocation des ressources dans les secteurs de la santé. Mais je crois que nous devons continuer dans notre approche globale qui veut que l'on puisse d'abord considérer la mobilisation, comme vous le dites là. Il y a au départ la mobilisation de ressources. C'est cette mobilisation-là, si elle est forte, qui va permettre d'accroître même les niveaux de crédits à allouer dans les secteurs de la santé. Et puis après, il y a une autre étape qui est celle de l'affectation de l'utilisation. On peut mobiliser des recettes, donc des ressources importantes à affecter au secteur de la santé, vous allouez, et puis après, il faut se rassurer que ces allocations-là ont été utilisées à bon escient. Donc, il y a un problème de gouvernance qui se pose. Il y a un problème de redevabilité. Donc, maintenant, peut-être, je vois au niveau de la deuxième proposition que vous aviez faite, vous avez parlé de... Il faut voir comment introduire les mécanismes pour réduire les dépenses personnelles. Et puis, au niveau de la troisième proposition, là, vous dites qu'il y a possibilité d'envisager des instruments juridiques relatifs à la mobilisation, à la location et à l'utilisation. Donc, je crois que nous devons, au niveau de chaque proposition que nous allons faire, tenir compte de cette approche-là globale. Nous ne pouvons pas séparer, par exemple, la location, la location des ressources. On ne peut pas séparer cette étape-là de celle qui consiste d'abord à mobiliser de ressources qui doivent être allouées au secteur de la santé et maintenant savoir comment est-ce que cela a été utilisé. Je parle par exemple de l'utilisation. Dans mon pays, il y a ces faibles taux d'exécution des crédits affectés au ministère de la Santé. Déjà, nous n'arrivons pas à allouer le 15% des crédits budgétaires dans le secteur de la santé. On est pratiquement à 10, 11, 12. Mais tous ces crédits-là qui sont alloués au secteur de la santé ne sont pas utilisés à 100%. Donc, il y a un faible taux d'utilisation de ces crédits-là. Je crois que la recommandation qui doit être faite, elle doit tenir compte de ces trois étapes-là. D'abord, la mobilisation de ressources, l'allocation de ces ressources-là, et puis après l'affectation et l'utilisation de ces ressources. Donc, tenir compte de ces trois étapes-là. Alors, si on tient compte de ces trois étapes-là, à ce moment-là, on prendra en considération les interventions des autres collègues qui ont notamment parlé de la redevabilité, tout ça. C'est un problème de gouvernance. Et vous savez que les problèmes de gouvernance varient d'un État à un autre, dans notre sous-région. Et peut-être pour terminer, je prendrai l'exemple de mon pays où, par exemple, les ressources des bailleurs de fonds ne sont pas budgétisées. Parce qu'on parle de 15%, là, je vois les efforts du gouvernement. Les efforts du gouvernement. Je sais que dans d'autres pays, les ressources des bailleurs de fonds font partie d'appuis budgétaires. C'est dans le truc. Mais par exemple, dans mon pays, au niveau du ministère de la Santé, il y a une cellule qui a été créée, appelle la CAG, une cellule qui est chargée de gérer le fonds des bailleurs de fonds. On n'a pas encore atteint l'étape où ces fonds-là sont intégrés dans le budget de l'État. C'est pour cela que je disais que c'est préférable que nous puissions appuyer cette déclaration-là d'Abuja qui a fixé le seuil à 15%, et dans notre proposition, inviter les États membres à pouvoir atteindre ces 15%-là. Maintenant, ça dépendra. Si dans certains pays, les appuis, les ressources des bailleurs de fonds font partie d'appuis budgétaires, il n'y a pas de problème. Même si tel est le cas, vous allez constater que même si ça fait partie d'appuis budgétaires, mais ils n'arrivent pas toujours à atteindre les 15%. A fortiori, par exemple, dans mon pays, où sous réserve d'être contredit par les spécialistes, par exemple, de mon pays, mais que je sache, dans mon pays, les ressources des bailleurs de fonds ne font pas partie des allocations budgétaires de l'État. Et si, par exemple, nous arrivons à atteindre par exemple, les 15%, là, le corollaire, c'est quoi? C'est que même le ménage, les foyers ne vont pas beaucoup dépenser dans les systèmes sanitaires. Parce que s'ils dépensent plus, pourquoi? Parce que l'État, dans une certaine mesure, il est défaillant. Si l'État arrive à atteindre le 15% des allocations et tout ça, et que ces allocations-là sont très bien utilisées, et que suivant le mécanisme de bonne gouvernance qui ont été mis en place, les poches des individus seront soulagées, les ménages ne vont pas utiliser d'autant parce que ce qui est prévu dans les budgets, c'est pour l'amélioration du bien-être sanitaire de la population. Merci beaucoup, je crois que c'est ce que j'avais à dire pour le moment.
Thank you very much, honorable member. You did really articulate your position quite well, and at this point in time, I do agree with your position and the rest of the honorable members. I would also want to give an opportunity to other honorable members that would want to deliberate on this matter. Even those who are online, I'm looking to have even the citizens in the gallery who may have some input to make. I don't seem to see anybody with their hand up. I see honorable member from Madagascar interested to deliberate, and honorable member from Eswatini again. I'll give honorable member from Madagascar the floor for now, and then they will be followed by honorable member from Eswatini. Thank you.
Merci, Monsieur le Président. J'aimerais soutenir la recommandation que notre prédécesseur ont déjà dit tout à l'heure. Nous sommes ici pour discuter des enjeux cruciaux, le rôle du Parlement sur le financement de la santé publique. Donc, on sait vraiment que le Parlement joue un rôle fondamental dans la mobilisation, dans l'allocation et l'utilisation des ressources nécessaires au financement de la santé. Ce rôle s'étend au plaidoyer pour la couverture sanitaire universelle et à l'assurance que les services essentiels tels que les soins de santé primaires et les déserts soient effectivement financés. Les parlementaires doivent activement soutenir les initiatives visant à renforcer le financement du système de santé en respectant les conventions d'Abuja, c'est-à-dire les 15% du budget de l'État alloué à la santé. On voit aussi que la participation citoyenne est indispensable, mais ça doit être soutenu par la mise en place d'un mécanisme qui génère des fonds alloués à la santé, tels que les taxes, l'assurance, et enfin d'assurer que notre système de santé soit financièrement durable et ces fonds sont utilisés efficacement et avec efficience. Enfin, la plateforme de partage d'informations entre les pays membres de la SADC doit être mise en place et utilisée. Et l'analyse continue doit être un outil de suivi de notre système de santé de chaque pays. Sur ce, Monsieur le Président, j'aimerais adhérer dans les recommandations qui ont déjà parlé tout à l'heure. Merci.
Thank you very much, Honorable Celestine, if I'm saying it correctly. At this point in time, I will allow Honorable Zumalo from Eswatini to also give a few remarks. After which, Madam SG, I would like to know if you would want to give final remarks before we consider the closure of the meeting. It doesn't seem like we still have additional input from members online or any other members, but we'll see after Honorable Member from Eswatini if it will trigger any reaction from Honorable Members. That was just putting it out there in case, Madam SG, you would have some remarks before we close. Thank you.
Thank you, Honorable Chairperson. I really, wanted to support what my predecessors have spoken about. In particular, what the Honorable Member from DRC spoke about in terms of us exercising duty of care in our oversight role in terms of making sure that whatever recommendation we make addresses the allocation of the funds, the distribution of the funds, and the utilization of the fund at all levels. So I just want to support what my colleagues have said, and also the issue of governance, good governance, that my honorable also from Zimbabwe spoke about. Pretty much, Chair, I think we are all moving in the same direction, and I do feel that we are saying the same thing to a very large extent. So yes, Chair, I wanted to support what my colleagues were talking about. I thank you, Chair.
Thank you very much, Honorable Zumalo. We have Honorable Member from Malawi who would like also to put their submission, after which then we'll consider Madam SG if we don't have any other member. The floor is yours, Honorable Member. Thank you.
Thank you very much, Honorable Chair. I should also congratulate my predecessors for putting up a well recommendation. Resource mobilization, it's always difficult for most of countries because most of their source of getting those monies are already exhausted. So the other avenue which we can take is to how to manage the already existing resources. Because if we go like in Malawi, most of the resources we get is from the taxes. So any other avenues are not there. So what do? We need to make a proper expenditure plans whereby we are able to follow all the monies on how they are spent. Because most of the times the monies which are allocated, let's say for health, are not totally used for health. You'll find that the bigger chunk of the money is spent on meetings, and allowances. The actual thing which we want to tackle is not financed properly. So that leaves a big gap for the actual target or the actual healthy care we want to give to the people. The government is there to support the poor, where it gives free medical services, low-cost services, but resource envelope. The resource envelope we have is the same resource envelope which is being abused for those who are taking care of it. Therefore, it is important that we make the mechanisms which can protect the resources so that the resources are pushed to the targeted action which we want. And the allocation. The other thing which I look at is the other alternative, maybe for the resources where we can get the resources.
Apologies, honorable member. Just want to confirm. Okay. Honorable members online, are you still able to hear us through?
Hello?
Are you still able to hear us, Madam SG?
Yes, we can hear. I can hear.
Okay, thank you. Continue, honorable member.
Yes, we have to look at some commodities and services which are totally luxuries. Those ones we need to put bigger levies so that we collect more money for support of the health care, because there are some of the services and goods which are totally luxuries. Thank you very much, Honorable Chair.
Thank you very much, Honorable Leonard from Malawi. If we don't have any additional submissions, I would therefore call upon Madam SG to see if you have any final comments before we can then close the meeting and the chairperson deliver their closing remarks. Madam SG, would you want to give any submission to the honorable members?
Thank you, Honorable Chair. Mine is really just to appreciate the level of discussion and engagement that has taken place. This is a good beginning because the journey is long. The journey is long in the sense that, Honorable Chair, the challenges and opportunities that the committee is deliberating upon will require us to really reflect on how brave we are, how committed we are, and actually look at the operating environment within which we promise to do some of these things. That is why they talk about money, the power of the purse. And that is another area which is actually very conflictual. And we must also recognize that we operate within very different political environments, where our standing orders, even if the first question was, how involved are you with the budget cycle in your country, and to what extent do you believe as an honorable member you are able to deal with that cycle of consultation, here and here, contribution in good time and things like that? I'm sure the reflection upon such will tell us we need to be brave and committed in that particular instance. So the issues that we raise, issues of public expenditure tracking, these are performance issues that we are taking upon ourselves. These are issues where we really need to engage with citizens. And for you to track, you cannot track alone. For you to track, you need to track within an existing cycle where the opportunities for contribution, where we are also going to be committed to look at the quantitative and qualitative components of whether we are performing or not. So indeed, I agree with you, honorable members. Let us look at opportunities for increasing resources. We have heard that the resources are not enough. We have heard that money is allocated on paper from some of you, that we really are agreeing that the budget needs to actually reach those who it's done for. We didn't use the same words, but I think there's need to significantly look at leakages in the system. That is where when we want to domesticate the public financial model law, we're looking at PFM systems so that where inefficiencies are there, they must be genuine, and these inefficiencies must also be corrected. Where spending may not reflect the intentions of our hearts and the love for our citizens, let us look into that and see what we can do. And I agree with all the members who spoke that a lot of times we don't really have an idea of the money that's coming in to our countries. And there's a reason. It's a power. It's a power. It's a power cycle that you should not, even at home, unless your family is very liberal, you can never know how much money the sources of funding in the family are, and you are not always privy to indeed what is the budget for this family, and so forth and so on. So I'm really saying this as a light moment, but also as a way of saying as we intend to execute, as we intend to collect the data, as we intend to put ourselves at the center of engagement with stakeholders, as we intend to give feedback among ourselves and to parliaments, it requires much more than just tracking. It requires a certain level of conduct. It requires you to also study your standing orders and how your parliaments or your country sees your role in this context. And it will require you to look at credible institutions that you can work with. It also requires you to look at credible partners within parliament, because the nature of the exercise requires collaboration. The heart may be willing, but we need to look at how best we are going to be able to take out this exercise. When we begin to track and report to the plenary, we are setting a very clear objective. We are also setting up a very clear participatory model for this committee. And therefore, we must be clear how we're going to allow and manage this process. I'm not saying it is impossible. I'm saying it requires concerted efforts from ourselves as individuals, from the system within which we work. Of course, it's easy, honorable members. We can go back to our research desk and say, give me information. SADC-PF wants to know this. But the findings or our commitment must constructively allow us to say we've critically looked at this process and we know the countries within which we operate and how far we can go. So, honorable members, mine is just to thank you. I think we have heard you. We have also been able to look at oversight intersections for this committee in terms of what we can do. We're also aware that we've placed a performance indicator for both our countries and our efforts to intersect and share this information in the long run. So thank you, Chair. Thank you, Honorable Member. I think I enjoyed this sitting for the past few days, and I'm looking forward to how this committee is going to institutionalize change that will happen linked to the stages of the budget. And for us to look within and appreciate what the challenges are and what is it that can be done to encourage and be able to constructively engage with the multi-stakeholders, from government to other stakeholders in our countries. And also, even when we get the support from CHAI, the support from CHAI also means that we must be able to process this through certain tools that are much more structured through this committee. From a more structured to formal macro level, government, etc. So thank you so much, Chair, through you. Thank you for such a fruitful day, and also for ensuring that the citizens see the seriousness at which committee deliberations actually are worthy of parliamentary engagement. Not only should they be relegated to ministers, governments, to the exclusion of governments, there is value in engaging governments. There is even much more value when the parliaments are involved to complete the exercise of consultation, engaging, and working together. Thank you, Chair.
Thank you very much, Madam SG, for your kind remarks. Uplifting remarks indeed. We are glad to hear that you have been quite motivated by how we have engaged this session, how much we have participated, and if it meets your requirement, we are very, very happy as honorable members. Honorable members, thank you very much for your time. At this point in time, we have gotten to the end of our meeting. I'm therefore going to be delivering my closing remarks, after which then I will call this meeting adjourned. Honorable Vice Chairperson of the Health of Human Social Development and Special Programs Committee, Honorable Lineta Karinye, all honorable members of the committee, Ms. Boyamo Sokhoma, Secretary General of SADC Parliamentary Forum, and the members of SADC Secretariat and staff, our committee secretary, Mr. Joseph Mansi, staff from national parliaments, esteemed resource persons, distinguished guests, ladies and gentlemen. We have now come to the end of our two-day meeting. From the onset, allow me to thank you, honorable members, both in this room and those that have joined us online, for your attendance and active participation during this meeting. You will agree with me, honorable members, that our meeting for the past 2 days has been successful. I'm sure we have managed to achieve the objective that we were set out for this meeting remarkably. We shared valuable experiences on the issues on health financing and SRHR service delivery systems from our respective countries. Secondly, we received expert witness submissions from our esteemed resource person, Dr. Matiko Riro from Clinton Health Access Initiative, and from the citizens who joined the meeting from the gallery, who shared with us their informative experiences on health financing globally and within the SADC region. Honorable members, the expert witness submissions were received during the meeting have been an eye-opener to us as legislators. They have assisted us to identify key issues and recommendations that will be included in our report to the 56th Plenary Assembly that will be hosted in Zambia in December 2024. It is my sincere hope that the recommendations, once approved by the Plenary Assembly, will go a long way in influencing our respective governments to allocate adequate resources on health in line with the 2021 Abuja Declaration in order to improve the lives of the citizens of the African region. In that regard, allow me to extend my sincere gratitude to our esteemed resource person, Dr. Matiko Riro, and the citizens, namely Vivian from SAYOF and Caroline Kwambogo in absentia for their valuable and informative submissions to the committee. I wish also to commend the Secretary General and all SADC PF Secretariat for their tireless efforts in organizing and facilitating this meeting and also guiding the members during the deliberations. Madam SG, your dedication and professional work have been instrumental in ensuring the success of our deliberations and the outcomes of this meeting. As we travel back to our respective countries, I would like to wish each one of you a safe trip back home. With these few remarks, it is now my singular honor to declare this meeting officially closed. Senedie. Thank you very much. Honorable members, the meeting is officially closed. We then can depart, take leave to our respective places to go have rest and safe journey for those who are traveling either today or tomorrow. Thank you.
Admin terminate the meeting.